we could go ahead and get started. I have an announcement. I wanted to say that yesterday was the 2-year anniversary of my kidney transplant. So for those of you that don't know, my aunt came forward and donated her kidney to me. So I just wanted to give a special shout out to her because that's why I'm here today. So yay. That being said, we will go ahead and get started. She might watch these every once in a while. So I like to give her a little shout out. So means a lot to me.
If you guys are in the CPR2 one, he did the shout out too, if you guys remember.
Yeah. So, all right. So the plan is I'm going to go through the stuff from the first week. What's good about that is a lot of this stuff is going to be carried over. Like you're going to see it again. So the first week was kind of a broad overview, and you're going to see a lot of the concepts come back again. So we're going to go through, I'm going to go through some of the high yield stuff, the anatomy, neuroanatomy stuff from the first week. Then Lindsey's going to go through some of the more molecular pathways, and then we'll take a break, and then we'll go through the tracks, which is by far the most important stuff to be able to understand to kind of work through these questions. So y'all know this, y'all know this. We do have extra stuff. I do believe I have questions on there. I don't know how many, but there's extra questions. My notes are on there. Also, some people spent a lot of time making charts and stuff with all the pathways. So go ahead and look at this stuff. Lindsey posts stuff as well, and see it. You know, if you like it, use it. If not, don't worry about it. All right. So we'll start here. So when we talk about the different, anatomical or embryological basis of the brain, it's broken up into 3 sections embryologically: prosencephalon, mesencephalon, rhombencephalon. But most importantly, it breaks down to the telencephalon, which is the cerebral cortex, the diencephalon. Then the mesencephalon stays the same, it's the midbrain. And then the rest of the brainstem, the metencephalon and myelencephalon. So I like this mnemonic: tel, di, mes, met, my. Just say it to yourself like 5 times, tel, di, mes, met, my, right? And then you just remember it, right? So that's what I use. So it correlates to that. Remember that the mesencephalon includes the cerebellum, right? So this is the brainstem. Mesencephalon is, I'm sorry, I put this wrong. It's metencephalon is the pons in the cerebellum. Sorry. So make a correction there. That's metencephalon. Mesencephalon is the midbrain. Metencephalon is the pons and cerebellum, and myelencephalon is the medulla. All right, so yeah, correct that. I'll correct the slides after as well. All right, and you can see this is from first aid, it kind of how it breaks down. But understanding this, you'll be able to answer some of the basic questions about the brain development. Remember, when we talk about the ventricles and stuff, the midbrain is about the area of the cerebral aqueduct, right? So when we talk about that ventricular drainage system, and we'll get to that a little later. Okay, so again, same thing, tel, di, mes, met, my. Yeah, let's do that, or not. All right, and remember, again, the cerebellum is included in the metencephalon, right? All right, and then quickly, if you remember this, like the muscle, individual fascicles are surrounded by the endoneurium. Group of fascicles are the perineurium, and the whole nerve fiber will be the epineurium. So that's just the general basis. And as for the arches, okay, let me prep. I should start with this. So this is how it works. They used to teach the cranial nerves really heavily in the first test, but with Lindsey and my term, they switched it. So they the cranial nerves are the primary part of the NB2 exam. Okay. Now the difficulty with that is that you kind of need to have a general basis of the cranial nerves to answer these questions. For instance, you're going to learn about vision, right? But you're going to learn in the concept of physiology that has to do with vision. So then you will correlate cranial nerve 2 to that, right? Whereas on the NB2 exam, you will take cranial nerve 2, follow it through the brain, and work it out. So it's more of like a different pathway of approaching it. But the sooner you can get these cranial nerves down, the better you'll be. But by all means, the second exam, when you start having to trace it through the brain or through the skull, it gets a lot more complicated. So general understanding of the cranial nerves right now will do. But again, the more you know now, the better off you'll be for the second exam. So just put this, these are the pharyngeal arch derivatives. Again, this is going to come back for NB2 primarily because you're going to talk about cranial nerves and you're going to be talking about the face. But these are the pharyngeal arch derivatives. Trigeminal, which is cranial nerve 5, comes off the first. Maxillary artery correlates to that. Facial, which is cranial nerve 7, you're talking about the motor, muscles of facial expression. That comes off the second arch. Glossopharyngeals 3, and vagus is 4 and 6. So this is from first aid. I used this when I did it. Like M's correlate to the first arch, S's correlate to the second arch. If you just look at this, you could kind of have a general understanding. I wouldn't go too far into details. You'll learn about some of these, Treacher Collins and Pierre Robbins, I believe, on the second exam. So just a general understanding of this and you should be fine. Same thing here, you're gonna get into it, but you could just follow this. The grooves, the only one you need to know, this is the external ear canal, external acoustic meatus. For the pouches, 1 correlates to the ear, 2 correlates to the tonsils, and 3 and 4 are flipped. What do I mean by that? So embryologically, they actually do flip. So the 4th pharyngeal pouch will correlate to the superior parathyroids, whereas the 3rd will be the thymus. So when we talk about like DeGeorge syndrome, that's a problem with these 3rd and 4th pouches. But again, just a general understanding, y'all are gonna go back to it on the second exam. So if you think of anything, now you're getting a general understanding of the tracts of the body. And on the second exam, you're gonna do cranial nerves and much more focus on the face. Okay, and this is again from first aid, but same principle, the 3rd and 4th flip. All right, so we're gonna look at the cranial fossa. So once again, this is more of NB2, but we're gonna lay down the foundation for what you need to know. So in the frontal, this red area here, the anterior cranial fossa, the only thing you really need to worry about is cranial nerve 1. The cribriform plate is kind of where it lays. So you have these olfactory bulbs, they call, kind of like if you see like an insect, right? Like they have these little bulbs. Well, ours just kind of sit in the skull, right? And it picks up the odoriferous signals, right? So for the smell. So that's the only one you need to know for the anterior cranial fossa. It gets a little more complicated when you get to the middle cranial fossa. So these are some things that you're gonna definitely need to know for the second exam. But for instance, the optic canal, cranial nerve 2 goes through there. And then after that, it gets a little bit more complicated. So superior orbital fissure 3, 4, 6, and V1 go through that. What do I mean by V1? So cranial nerve 5 is the trigeminal nerve. It has 3 branches, B1, B2, and B3, all of which are important. But I just want to say one more time, like y'all definitely going to get into this more on the second exam, right? So I'm just trying to lay down a little bit of foundation. I don't want to get too far into it. So that's going to go through the superior orbital fissure, which you could see here. It kind of like it leads to the eye area, right? Because a lot of these, actually all of these besides V1, have to do with eye movement. Yeah. And okay, and then the foramen rotundum, it's kind of on the side here. That's going to correlate to V2, which is the second branch of the trigeminal. And then ovale kind of looks like an oval here that correlates to V3. So there's little ways to remember these things. So the superior orbital fissure, again, 3, 4, 6, and V1 are going to go through there. And then ROS, that's how I remember these, rotundum, ovale, spinosum, right? So ovale is the larger one, spinosum kind of looks like a spine if you look at it at the correct angle. So V2, V3, middle meningeal artery goes through the spinosum. Why is the middle meningeal artery always important? Because whenever you get an epidural hematoma, that's the artery that's injured, and we'll get to that later, but that's a good buzzword for y'all. Good thing to remember. Now we get to the posterior cranial fossa, the main base of the skull. So there's some important things here. Remember that 7 and 8, the facial and the vestibulocochlear always travel together. They're going to travel through this internal acoustic meatus. 9, 10, and 11 go through the jugular foramen. 12 makes sense, goes through the hypoglossal canal because it's the hypoglossal nerve. And then the foramen magnum, the big base here where the spinal cord comes through, the vertebral arteries and the brainstem. Right, so just a general understanding of this. And this is from first aid. It kind of has everything put together if you want to test yourself with that. Now for the brainstem, let's see. Yeah, so once again, this is much more going to be on the second exam. They're just totally giving you an introduction to the stuff. But there are, eventually you're going to have to be able to draw this out to know where everything comes from, especially when you do axial cuts of this. You're going to do axial cuts all the way down the brainstem to see where the nuclei are and where the cranial nerves correlate. And this is going to lead you to be able to say, like, if there's some sort of arterial injury in a certain area, like the anterior spinal artery, what nerves are affected or what nuclei are affected. So they do go down in order, so that helps. One of the tricks, the ones that are purely motor stay medial. I think I have a slide coming up to illustrate that. So a good way to remember this is 4 are above the pons, 4 are in the pons, and 4 are below the pons. So cranial nerves 1, olfactory, and 2, optic, are in the brain. 3 and 4 come off the midbrain, and then 4 in the pons, 5, 6, 7, 8, right? Those 4, and then 4 below the pons, 9, 10, 11, 12. All right, so keep these in order. So I like it, you could say 2, 2, 4, and 4, right? 2 in the brain, 2 in the midbrain, 4 in the pons, 4 in the medulla. Okay, whatever works for you, just kind of have a general understanding of where those are now. And let's see, again, just another image from your notes. And remember that vertebral artery, that complex with the basilar artery, is going to run right here over the anterior side of the brainstem. So you're going to see a lot of questions based on like pica injuries or ICA injuries relating to the posterior inferior cerebellar artery and stuff like that. But I have some more slides with that coming up. So this is where I pulled it from. This is from first aid. 4 above the pons, 4 in the pons, 4 in the medulla. And then they also talk about this, these medial ones, 3, 4, 6, and 12, they run medially on the actual brainstem, and those are purely motor. The ones on the outside, a lot of them have a sensory component and a motor component, but like, for instance, the vestibulocochlear is purely sensory. So if this is foreign to you, I don't want y'all stressing. I'm just kind of laying down the groundwork. This is a lot of NB2. All right, and again, this is very important. We're going to talk about this a little later, this vertebral artery complex. So remember, there's 2 ways to get blood to the brain, through the carotid arteries and through the vertebral arteries, right? The carotid artery is going to primarily give you blood to the middle and anterior cerebral artery, so the front of the brain. And then this vertebral artery is going to give rise to the posterior cerebral and to the cerebellar. But we're going to look at these on angiograms. But you should be, this is one of those things, I'm not crazy about drawing stuff out, but this is one of those things like you can definitely draw out. Very importantly, this circle of Willis is here. So it connects the blood supply that's coming from the carotids, which you see here, to the vertebral arteries. Very importantly, if there's some sort of lesion or some sort of stasis of blood on one side, or injury or aneurysm, you can get collateral blood supply through the other side, right? Of course, so that makes a lot of sense. That's the point. So that's the good, that's what's great about the circle of Willis here. You can get blood supply if there's some sort of injury. We'll talk about this a little later, but remember, so these larger arteries, such as the carotids, are high pressure, right? These little connecting arteries, like the anterior communicating artery and the posterior communicating artery, those are basically right angles, right? So there's a lot of high pressure blood that's getting into these smaller arteries. So those arteries are very commonly suspect to aneurysms, okay? So when you see aneurysms, a lot of times they talk about aneurysms in regard to the anterior communicating artery, which is this right here. And its proximity to the optic nerve. I believe y'all had a question about this in one of your practice questions. So it is close to the optic nerve. So if you have an aneurysm in this area, you can injure that. Okay, again, yeah, okay, so yeah, let's talk about this. So when we talk about these injuries, posterior cerebral artery, if they talk about some sort of problem with 3 and 4, right? So some sort of eye problem, eye movement problem, a lot of times you're thinking of posterior cerebral artery. So one of the things you have to differentiate is, are we talking about a lesion somewhere in the brain, or is it in the brainstem? So a lot of times they'll give you symptoms from 2 cranial nerves, so or even more. And a lot of times that will correlate, that'll say it's more likely in the brainstem because you're knocking out 2 cranial nerves or 2 cranial nuclei in the process. All right, so if they talk about the ICA, which is anterior inferior cerebellar artery, 5, 6, and like I said, 7 and 8 travel together. So like, for instance, they'll give you some sort of hearing problem, some sort of ipsilateral ipsilateral facial paralysis that goes along with it. And you could say, well, it's most likely going to be somewhere in the brainstem, maybe even at the ICA. Then when we move down, 9, 10, 11, 12 correlate to the pica. The pica comes off of the vertebral artery, okay? The ICA comes off of the basilar artery. So these vertebral arteries come together, right? There's 2 separate ones. The basilar artery kind of straddles the middle of the brainstem at the pons level. So if you're looking at it on an angiogram and you're like, where is it, the pica or the ICA? Remember, the pica is going to actually come off of one of the vertebral arteries. Once you get to the ICA, once you get to the basilar artery, you see the ICA come off. Then as you get to the top, the superior cerebellar comes off, which is the small one, and then the final split is the posterior cerebral. So there's basically just four branch points you need to know. So the vertebral, the pica comes off of the vertebral, you get to the basilar, the ICA comes off. Then the small one here is the superior cerebellar, and then the large one is the posterior cerebral. Okay, so get those down. And again, when we come to the other aspect of the blood supply, the second route is from the carotid, which is going to give rise directly to the middle cerebral artery. And then through this communicating branch, you get the anterior cerebral artery. Okay, so think of the carotids correlating with the anterior part of the brain, and the vertebrals correlating to the posterior part, and they connect through the circle of Willis. All right, I wanted to slow that down and make sure y'all got that, because this is going to be it's a very important testing point, because it tests a lot of things. It tests, do you know the blood supply? Do you know the cranial nerves? Do you know the lesions? One more thing, the cranial nerves do not cross, okay? So once you get to the brain, they'll cross, like your right brain will control your left face. But when you talk about the cranial nerves, which are considered peripheral nerves, they're not in the CNS, okay? They're considered in the PNS, the peripheral nervous system, right? So they don't cross. So for instance, 8, the vestibulocochlear goes, the right vestibulocochlear goes to the right ear, okay? But again, once you get to the brain, then they start crossing, okay? That's enough of that. Yeah, we'll talk about the alar and basal plate in a second, but this is just from first aid if you want a little more clarification. All right, this is weird. So we're gonna talk about this because you'll probably have a question about it. So this makes sense, right? Anterior, posterior. If anything, think about the skull, right? Because we're gonna get to the brainstem in a second. But this all makes sense anatomically. That's the anterior part of the skull, posterior part, medial lateral. This is where it gets weird. All right. So basically, they define the brainstem as being upright. So let's look at it like this. This is what they said, which makes sense, right? Rostral and caudal is the tail, ventral and dorsal. But what happens is, through development, the brain kind of turns over. So this is what happens. So they kept the naming system based on this. Okay, so let's just, I blurred this out so we could just look at the part that flipped over, right? So make this make sense in your head, right? This is still the top of the brainstem. This is still this, it's just turned over, all right? This is still the dorsal side, right? It's just turned on its side. This is still the ventral side. This is still the caudal side, okay? This is how they did it. Sometimes I get confused and I just put my head straight up and it straightens this line out and it makes sense to me. I don't know. If that helps, you could do that. But just make sure you understand this, because this will be both the rostral and anterior part of the brain. This will be the caudal and posterior part of the brain. But the reason it's labeled such, the reason it's labeled like this is because it's turned over, okay? It was initially labeled when it was upright. then embryologically the brain kind of kicked over. So rostral is anterior. The bottom side of the brain is going to be ventral. The dorsal side is going to be the top. Okay. I remember them asking questions about gunshots going through somebody's head and asking you the directionality of it. So you kind of need to know where these go. And you could see that here. Rostral and caudal means tail. So the rostral is the anterior, caudal is the posterior. And then once you get down past the point where it kicks over and it goes upright again, it goes back to normal. Rostral's the top, caudal's the bottom, ventral's front, dorsal's back. But again, anterior stays the same. Okay, so make sure you have that down. All right, let's get into the brain, right? So frontal lobe, that's kind of what makes us humans, right? We're able to process things in a more logical fashion. The temporal lobe has a lot to do with hearing and being able to process sounds. Parietal lobe is more of like, I like to think of it as more your artistic ability and has to do with spatial awareness. And occipital lobe is vision. And obviously there's a lot that goes into that. That's just a very simple outline of it. The limbic system in here is our primitive brain. This is our emotional cortex, which you could see. And then the corpus callosum, we'll talk about that in a second. These are those fibers that cross over. So very importantly is this central sulcus. It separates the frontal and parietal lobes, but for testing purposes, it's going to separate the primary motor cortex from the primary somatosensory cortex. Okay, so they love to test on this. This is where the homunculus comes in. So also some good testing points. This junction between the parietal and temporal lobe is Wernicke's area, where you process sounds coming in. I think of it like afferent, right? So sensory of sound, and then Broca is more of that efferent, right? You're speaking sounds. But we'll talk about that in a second. Broca's is kind of this in the lower aspect of the frontal lobe. Okay, so gray and white matter is switched in the brain from the spinal cord. If you think about the spinal cord, the butterfly in the middle is gray matter. That's the cells, and the white matter on the outside is the tracts. But think about this. I find this very interesting. The gray matter is the cells, right? And white on the inside in the brain is the tracts. These cells, this little layer over here, there's 100 billion cells here. But look how much more dense the tracts are. That just tells you how interconnected the brain is by being able to communicate so well, because the white matter on the inside has so much more space occupying capacity than the 100 billion cells on the outside. So you could just see how interconnected and how interwoven this is. It's kind of comical at this point what science knows about the brain. I mean, we're like literally, it's like the tip of the iceberg. I mean, we really are on the basis of understanding it. So it's quite fascinating. So again, the spinal cord, the gray matter, the butterfly is on the inside. In the brain, the gray matter is on the outside. And then this insular lobe, not really talked about very much. It has to do with interoception, visceral sensation, and taste. So like, it has like GI stuff, and just a lot of visceral type automatic processing that goes on there. So it's not super important, but you should just kind of know where its location is. Always try to correlate something in a coronal section versus the axial section versus a sagittal section, because it's kind of difficult to correlate them because of the different cuts. Now, I did post an interesting app. It's a very basic app, and there are much better 3D apps. But the reason I like that app is because the images look like this. And this is how the teachers are going to present them on the exam. They're just little blots, right? So you can kind of test yourself and see if you can orient yourself in the different cuts. So that's very important because it's not exactly intuitive when you do this. All right, and when we get to the basal ganglia, y'all are going to talk about that, I believe, next week. It gets really confusing with the tracts and the inhibitory dopamine tracts. But for now, I like to think of this. So this is a coronal cut. I like to think of this as kind of a face, right? So those are the eyes. This is the nose. This is the mouth, right? And then the substantia nigra, which is dopamine, is kind of like the goatee, right? I don't know. So the thalamus will correlate, this green area will correlate to the cheeks, okay? You could see the lateral ventricles come down, and then it'll drain into this ventricular system. So just some nomenclature here, the caudate, which is here, Very important structure because it atrophies in Huntington's disease. We had a number of questions pointing to this area and saying what happens if it atrophies, what happens if these ventricles are dilated because of atrophy here that leads to Huntington's. If you remember, that is one of those anticipatory genetic diseases that has to do with movement disorder, choreiform movements. But y'all will get into that a little later, but just for the anatomic purposes, that is where it's located. Now, the putamen, which is here, and the globus pallidus, both internal and external, those make up the lentiform nucleus. So all of this together makes up the basal ganglia, and the basal ganglia has to do a lot with movement, right? So you think about dopamine type pathways, but so make sure you understand that. And then this white matter tract that separates them, that's going to be the internal capsule, right? So it's just tracks, but we're going to talk about that later. So just again, we're trying to get some of this neuroanatomy down, because once they start getting into the physiology, you'll kind of be able to put the 2 and 2 together. All right, and this is a different cut. So this is one of those examples where it's really difficult to tell. This orange area here is actually the ventricle, right? So it kind of makes us see, I guess Dr. Kirkby did the C thing for y'all. It kind of helped me orient myself. But there was a question where they took like a coronal cut, right? And it went like through here, and it included this little tip of the ventricle, and it pointed to that as where is cerebral spinal fluid. I don't know if y'all remember that, but it was a very tricky question because you were like, it's not pointing to anything up here, it's pointing to something down here, but it was a different cut. It was a coronal cut. But just remember that, you know, if since they make these C's from anterior to posterior, if you take different cuts of it, it's going to look different. So again, that's why looking at one of those imaging studies will help you orient yourself there. And then again, you could see this basal ganglia, the caudate nucleus, which is kind of up at the, you know, the anterior side, or excuse me, the lateral side of the ventricles. And then you have the other parts of the basal ganglia kind of towards the outside. I think they did give you all some sort of app with a small group where you could actually look through the MRIs and like go through it and see it piece by piece, kind of like they do in the hospital. So it may be good to look at that so you can kind of see the progression. But understanding this in 3 dimensions is one of the most difficult parts, because it is kind of, it's changing very quickly as you move through the different cuts. So the better you can get at that, the easier the anatomy will get. All right, a couple more anatomical structures. The hippocampus has a lot to do with memory formation. You could see that here, and you could see it here in this coronal cut. The amygdala is the most anterior part, anteriorly right before the hippocampus. Amygdala deals with fear perception, right? So y'all will get into that a little bit later as well. But you want to be able to notice these because there's a few diseases that correlate to, you know, with the hippocampus, it has a lot to do with memory formation. So there's diseases that correlate to that. And everybody's favorite Kluver-Bucy syndrome has to do with amygdala lesions. If you're not familiar with that, go look it up. It's very interesting. Thalamus, again, like the cheeks, right? And so those are there. And that is a relay center, right? It's a relay center for the sensory cortex, amongst other things, to help fine tune your movement and process them. So, and you could see that here. So, you know, if you can overlay these pictures so you could see the different cuts and how they lay, it'll help you with the anatomy. All right, so there are 3 different tracks we need to worry about. The association fibers are going to connect 2 regions within the same hemisphere. The good example I like is the arcuate fasciculus. So when we talk about Wernicke's area, how do you get this sensory input of sound to understand it as from Wernicke's area to where you can speak in Broca's area? Well, there's this arcuate fasciculus, which is an association fibers, which connects Wernicke's area to Broca's area. So if somebody has a problem understanding you, right, understanding the words and being able to process the input of sound, you think it may be a problem with Wernicke's area. Now, if they have a problem with Broca's area, they have a problem speaking words. They can understand you, but they can't speak words properly. Then maybe it's Broca's area. But what's interesting about this arcuate fasciculus is there's a way to test for it as well. you try to get the patient to repeat what you've said, right? And if the patient can't repeat what you said, it's kind of a combination between the two. So what it ends up being is some sort of lesion in this arcuate fasciculus, because repeating has to do with both input and output, right? So if that helps you remember this association fiber between the same side, right? Because Wernicke's and Broca's are both on the left, right? So this arcuate fasciculus, that's a good way to remember it there. Now, secondly, you have this commissural fibers, right? Those are going to connect the right brain from the left brain, right? So they can communicate with each other. Interesting thing about this, if y'all go YouTube, some people with chronic epilepsy, right? They have seizures, hundreds, maybe thousands of seizures chronically a day, right? They're intractable. There's nothing they could do about it. What they've done is they've actually separated the corpus callosum. So they've cut it in, you know, cut it longitudinally or in a sagittal cut. And so they were able to stop the seizures by completely separating the right and the left brain, right? Because these commissural fibers tell the right brain and left brain what each other are doing. And by doing that, what they saw with these epileptic patients is like, it's almost like two different bodies. Like the right hand would try to like grab something to drink and the left hand would like put it down. Like it was literally like the brain couldn't communicate with itself. So it was kind of battling each other, each side. So that if you go YouTube that, it's quite interesting. But these are those commissural fibers between the two areas. And the corpus callosum, see, right? So that makes sense because the right brain's connecting to the left brain. You could see that here. And again, if you cut, like I was saying, if you cut through there, like with these epileptic patients, there's no communication. So it's just very interesting to see how that actually works. And you could see this on a axial cut. This corpus callosum is going to help connect the two there. All right, and then there are projection fibers. The one we primarily talk about is this internal capsule. They're going to give you some sort of lesion that has to do with the internal capsule, and you're going to have to know, what the symptomology of it is. So when we talk about, both motor commands and sensory commands, well, motor commands are going to come from the brain and go to the muscle. Sensory commands are going to come from the body and go to the brain. But both of them take the route of the internal capsule to get up here to the gray matter, right? So if you have a lesion here, you can affect a lot of the gray matter on the terminal end of that, right? So we're going to look at some other pictures of the internal capsule there, but for instance, a good example is motor commands that come from here, take the internal capsule, get to the cerebellum. And as you know, the cerebellum kind of is able to fine tune movements and integrate sensory aspects of movements in there. Excuse me. So by doing that, you can track through the internal capsule. So that's a good example of the projection fibers. So know those three: association fibers, commissural fibers, and projection fibers, because those are easy points on the test. All right, when we get to the diencephalon, primarily you think about the thalamus. The hypothalamus is there. Pituitary gland, the pineal gland, which has to do with melatonin and sleep and your circadian rhythm. So that's that diencephalic area there. And then we'll get down to the brainstem again. Tel, di, mes is membrane, midbrain. Tel, di, mes, met is pons and cerebellum, and my is medulla, right? So now, this is tricky, so you got to get this down. There's the images when they just take just neuroanatomy slices, right? So like in the lab, they're going to be oriented this way. So, and Haynes has this little flip arrow to let you know that they're flipped. You'll see that in the atlas, which the sooner you look at, the better you'll get at looking at these. But when you look at an actual MRI or any sort of scan, so for instance, the Mickey Mouse will be upright. But when you look at specimens or cuts, they're going to be flipped. Why they do that? I believe back in the day, they always did it like this, and then they got, MRIs came about, and it's just easier for surgeons to look at it when it's upright. So just be able to notice it in both different ways. But if you see excess brain around it, right, it's probably a live specimen or a live patient, really. So it's going to be in this orientation, right, with the anterior side in the front. and you can see here, they're flipped because the ventral side's on the bottom, right? So your classic spinal cord images are going to be this way, right? Ventral, dorsal, right? Motor, sensory in the brainstem. But so be aware of that. Also, I know there are some terrible pictures of MRIs like in the notes. I really didn't go into those too deeply, trying to like orient myself just because they were so blurry, right? So focus on these and just be able to orient yourself, just be able to flip them for the exam. So this is an example of a specimen, a cut. So you can see the ventral sides on the bottom and the dorsal sides on the top. But this is what I was telling you about. This is straight out of Haynes. So you could see this anatomical orientation, which is this one, right? And then the clinical orientation, which is this. So these are those blurry slides I was talking about, but you could see the Mickey Mouse is upright. So this is a live patient, and then this is a cut, right? So just be able to orient those, and you can see yourself. But again, if you see Mickey Mouse, you know you're in the midbrain. The cerebral aqueduct, the ventricular system that connects the third ventricle to the fourth ventricle, is going to travel right through there. So that's a good landmark for you to know. All right, and you can see the pons. It's a little bit bigger. You could see that the fourth ventricle is a lot larger. So once the cerebral aqueduct goes to the fourth ventricle, it kind of widens out. And this is going to be another thing in the second exam that y'all are going to get better at, but just orient yourself now and know that these pictures are flipped. Don't waste your time looking at these blurry pictures though. All right, cerebellum, again, it has to do with fine movement. Y'all get into that a little bit later as well. And then again, I'm just showing you the flip. One little trick, if you look at this, these are called the olivary, the olives, right? These little worm-like structures. That means you know you're in the medulla. And at the lower aspect of the medulla, it looks like this. You can still kind of see the olives. This is where the tracks, some of the tracks are going to cross the lower aspect of the brainstem. So we're going to get to the tracks later, but just know this is about the area where they decussate, right? Decussation basically means crossing, right? So the lower aspect of the brainstem, the tracks are not as bad as you think. I promise we'll work through them and you'll know them by the time we're done. All right, so we could break we kind of talked about this. So again, a lot of this basic neuroanatomy is not super high yield, like when we go into these different gyri, but knowing the specific areas, and I have a slide with the Brodmann's areas you need to know as well. Those are going to be important. But if you, y'all have been doing those small groups, so they kind of break these down. But as for testing purposes, I don't think actually knowing the specific gyri came into play. It was more about the areas that you talk about, like Wernicke's and Broca's.
I had a
temporal lobe. Yeah, sure.
On the images of the medulla, how can you tell, like,
Yeah.
it's like that staining confuses me with the white matter. So like, how can you tell where that's tracing?
Yeah, that's a good point. Honestly, I just kind of take a snap picture in my brain to kind of orient myself to where I'm at, but then I try to overlay the cartoons in it, because there's a lot of intermixing between white matter and gray matter when it comes to these areas. But if you kind of have this cartoon diagram in your head, you could kind of overlay it on there, and you can kind of see where the nuclei are. But this is going to come into play when you talk about the specific arterial lesions, like pica lesions or anterior spinal artery lesions, because if you cut out a specific area of the blood supply, you're going to knock out some of these little colored nuclei. But yeah, as for white and gray matter, it gets tricky because there's so much going on. It's not as simple as the spinal cord. There's obviously tracks coming off that correlate to the cranial nerves. So the best advice I could tell you is try to, just by looking at this, say, okay, I am in the lower aspect of the medulla, and then try to recreate this picture in your mind to kind of know a little bit of where the different, the main important nuclei are.
Thank you.
Yeah, no worries. Okay. So Wernicke's area is kind of, they kind of put it inside, but it's really, they talk about it as the temporal parietal junction, right? So it has to do with, I think it's 44 and 45 are no, is it 21.
So that's
Somebody help
21
me.
or 20,
21, 21, 22. Okay. And then this primary artery, this auditory complex is 41. I have another slide coming up we'll look at. Obviously, I forgot them. So that's how important they are, but know them now. All right. So this is important because what you see here as this parahippocampal gyrus, this is often correlated or spoken about as the uncus. You can see it here. All right, so when you have some sort of hemorrhage in the brain, particularly a high pressure hemorrhage, such as an epidural hematoma, that blood that's coming into the brain is going to put pressure on the brain, and the only place for the brain to go is down through the skull, through the foramen magnum. So the first area that actually protrudes through the skull is the uncus, all right? That's why it's called an uncal herniation. Now you could see this is actually cranial nerve 3. This is 2, right? This is the optic chiasm. You see these large areas here. See the mammillary bodies right there. But this right here is cranial nerve 3, oculomotor. So it has to do with eye movements. So when this uncus herniates through because of some sort of high pressure, like an epidural hematoma, when this uncus starts herniating through the foramen magnum, it's going to put pressure on this oculomotor nerve. So if you ever see something with the uncal herniation, or you see some sort of problem with the oculomotor or cranial nerve 3, a lot of times you're thinking of some sort of herniation there because of the proximity. So just know that the uncus or uncal herniation is usually the first sign of some sort of high pressure hemorrhage going on in the brain. We're going to look at the different herniations when we talk about the pathology, or when I'm talking about the physiology behind it. And then again, I put this in here for completeness sake, but they're not going to have any pictures where they just point to a specific gyri and say, what is that? They want you to know the functionality of it. The medial side, okay, so this is important though, because remember this right here is going to correlate to the central sulcus, right? So this anterior paracentral gyrus is going to correlate to the motor movements, right? The primary motor cortex. So if you remember the homunculus, this is going to correlate to the leg and the genitalia. The posterior right here is going to correlate to the sensory aspect of the leg and the genitals. So you could kind of follow. I have another slide. This is a special fissure here that kind of correlates. I think it's called the Sylvian fissure, and it kind of makes an S here. And when it comes up, it separates the two. But understand, if you flip the brain around, you could see that this would be that large central sulcus, right? It ends there. This aspect is going to be the motor. Posterior paracentral gyrus is going to be the sensory aspect. Here we go. Right, so cingulate gyrus, follow it up, and you can see that it comes here. So the central sulcus is right there. That's going to separate your frontal and your parietal lobe. But remember that the parietal lobe is going to deal with sensation, somatosensory, and the frontal lobe is going to correlate with this motor aspect. But they like to test about this because they can tell you the patient has some sort of problem with the lower limb, right? And automatically, you know, you're in the medial portion of the brain, and they like to talk about this paracentral gyrus. Okay, again, same thing, follow the Sylvian fissure up. The side that's anterior to it is going to be motor. This posterior aspect is going to be sensory. All right, here we go. Here's the Broca's area. That's right. So 44 and 45, that has to do with Broca's area up in the frontal lobe. And then 22 and is it 22 and 23 have to do with Wernicke's area. The somatosensory cortex is 1, 2, and 3, or 3, 1, and 2. And then the motor cortex is going to be 4. You could see here on this lateral side, this is going to be that important central sulcus right here, separating the frontal lobe from the parietal lobe, separating the primary motor cortex from the primary sensory cortex. So just try to orient yourself, find a few little landmarks in the brain, this one being important, this central sulcus, to kind of, find your way. Personally, I think the brain looks like a boxing glove, right? So you always know where the anterior side of the brain is by where the thumb is, right? So the temporal lobe's kind of like the thumb of the boxing glove. So the thumb's always going to point forward. So I'll look for that first. You see the temporal lobe, then you can find the central sulcus, see the occipital lobe back here, and you can kind of go from there. All right, we talked about the olfactory system. These are those bulbs, like I was saying, like antenna, right? So they allow smell here, but that's all you're really going to worry about down there, this orbital gyri. That's all they really talk about in this region. Again, this is more of just getting your bearings. So central sulcus here, the area just posterior to that is the posterior or the somatosensory, primary somatosensory cortex. And then some of these areas in the parietal lobe help to do with spatial awareness. But again, this is more to just orient yourself. All right, so what we're looking at here is the limbic system. As I said earlier, this is that that primitive brain, that emotional cortex. So this, you can see here, consider the cingulate gyrus and the sylvian fissures, what runs just above it. So it's going to separate that limbic system or the limbic lobe from the frontal and parietal lobes. So you can see that here, and there's a couple of little landmarks. The subcallosal area, the isthmus is there. I don't know, again, it's not going to be first order questions where they just point to an area and ask you what it is. They're going to be more of a clinical vignette. And one more time, we're looking at that sylvian fissure, right? And that's cingulate sulcus, or that limbic system that's underneath. The corpus callosum, again, remember, those are those commissural fibers that cross, connecting the right brain to the left brain, telling each other what's going on. So those are those crossing fibers. It runs just inferior to the limbic system, okay? And then when we get to the occipital lobe, this is going to be important, differentiating the cuneus from the lingual gyrus and this calcarine sulcus, just because when you start to talk about vision, it gets a little confusing because what you see in the eye fields kind of switches as it goes to the brain. I don't want to get into it right now because y'all are going to do it later, I believe next week. But knowing these will help you differentiate you know, if there's some sort of visual field deficit in a specific area of the eye, you can locate it to a different area of the brain. Okay, when we talk about the ventricular system, remember that the lateral two ventricles are going to come together at the interventricular foramen to connect to the third ventricle. From the third ventricle, you're going to go down through the cerebral aqueduct, right about the area of the midbrain. How do you know this is the midbrain? Well, find the pons. The pons is huge, right? And then that's the midbrain, and you could see that cerebral aqueduct. So if you look at the Mickey Mouse, you could see that this is what goes through it. That little hole that goes through it is the cerebral aqueduct. And then here you get that fourth ventricle. Okay, so when we talk about, we're going to mention this in a little bit, the different sorts of hydrocephalus. When we talk about some sort of obstruction here, it could obviously lead to backflow or a buildup of CSF in the brain, which obviously is not good. All right, and again, we're traveling down the cerebral aqueduct. We get to this area towards the lower aspect of the pons, kind of opens up to this fourth ventricle. And y'all know this by now when we talk about the spinal cord, gray matter on the inside, white matter on the outside. But we'll get into this when we get to the tracks in a second. Okay. And you know this by now, P is on the inside, arachnoid, dura, meaning tough mother, is that outer aspect. So when we talk about subdural, we'll get into it in a second, but subdural is below the dura, subarachnoid is where you get CSF, and that's going to be below the arachnoid, subarachnoid. And so, and remember the pia is kind of like saran wrap around the brain. Nothing really separates it. So, but we're going to look at those in relation to the different hemorrhages, because it's going to be important that you know where the hemorrhages are actually located in the different meningeal layers. Okay, let's look at some neuroimaging. This is going to be very important. So you need to orient yourself and be able to look at these and kind of tell what you're looking at. So first thing you need to ask, are we looking at the carotid pathway, or are we looking at the vertebral pathway? So you can see there's no midline basilar artery here. That would indicate that it's vertebral. What you're looking at is actually the carotid artery, and it kind of makes this little carotid sinus or siphon, excuse me, as it travels into the carotid canal into the brain, right? So you can see it comes from the outside, right around here on your neck, and then comes into the brain, and you could see it's branching. The two main branch points See, 4 is the middle cerebral, getting blood supply to the outer aspect. And 3 stays medial, and that's going to be the anterior cerebral artery. So it's going to supply the frontal area and that midline area of the brain. So first orient yourself. Is it the vertebral artery, or like we're looking at here, is it the carotid artery? And then you could kind of find your way there. Let's see, again, we're looking at it here, carotid artery, you could see it kind of curve as it goes into the brain. And then what would we expect? We would expect 4 is middle cerebral to the middle aspect of the brain, and 3 is anterior, and it's going to travel kind of medially. And 4 is going to be on the more lateral side. So if you were just trying to look at this and you were like, I can't really tell from here, ask yourself, are we talking about the anterior portion of the brain or the posterior, right? Because if it's the anterior, we're looking at primarily, it's going to be the front coming from the carotid. If it was coming from the vertebral arteries, it's going to give rise to the posterior cerebral artery. So you're going to be worried about looking at stuff in the back. All right, really easy question on the test. If it has a white background, it's digital subtraction, or DSA, right? It's the same thing. They just flip the colors around, and as you can see, it's just easier to see. It's easier to see the vasculature if it's flipped, right? So they just artificially flip it around, whites to blacks, blacks to whites. So if it is a white background, you're looking at a DSA. Okay, so, and then you need to orient yourself to what we're actually looking at scan-wise. So what we're looking at here, the bone is lit up really bright white. So that's a CT scan. So a CT scan is a glorified X-ray, right? It's just much more powerful. You can appreciate the white bones on the outside. That gives it away right away. And what CTs are really good for is for looking at some sort of hemorrhage, some sort of fluid in the brain. So if somebody comes in with a really bad headache, some sort of cranial nerve problem, and you're worried about a hemorrhage, you need to get a CT and see if there's any sort of blood pooling. So CTs are really good at looking at some sort of blood. Again, look how white the bones are. Immediately, you know that it's a CT. And look, you see this white fluid here. That's indicative of a subarachnoid hemorrhage. Okay, you can see all this white pooling around the circle of Willis. Now, there's 2 different types of MRIs. You need to know the difference between the 2. The T1 is going to be dealing with fatty tissue. So most of the time they use this, they're looking for tumors. You could see, let me just break this down real quick. So whenever you're looking at pathology, right? So let's look at this one here. What you want to do is split the brain in half, and you want to look at both sides, and you want to differentiate what looks different, right? Because they should look the same. So if there's anything that looks different, that would probably be indicative of some sort of pathology. So you could see here, this fatty tissue, this is probably some sort of tumor formation here, right? So so that's all you do. You just want to split it in half and look for differences. Now, T2 MRIs, you're going to be looking for some sort of edema, some sort of fluid buildup. So to differentiate T2s, T1s from T2s, remember T2s, the fluid is going to build up. So you're looking primarily for CSF. You can see here these inside all these little cavities, inside all these sulci, in between the gyri, cerebral spinal fluids built up. Look at the ventricles, right? They're all lit up, right? That's because there's cerebral spinal fluid in there. So even when you look at like a sagittal cut of the spinal column, if you want to differentiate the 2, you try to look for CSF, because again, a lot of times water goes with fat, right? So it's hard to differentiate. So you need to find an area of fluid that doesn't have fat in it. So conveniently, the CSF is what you want to look at. So if you're differentiating T1 from T2, look for some area where you would expect to see CSF. And if you see it, that would indicate that it's T2. All right, and so a good differentiator here. How would you differentiate this from this? Well, look at the fluid, right? You have fluid in all of these sulci and this edema here. But again, the ventricle should light up. The areas in between the gyri should light up. This T1 is a fatty area, so you're looking for some sort of tumor formation. Here's a good example. How do you know this is T2? Well, look here. So you might say, oh, well, that's fat, right? That's like back fat. But fluid always goes with fat. Typically, it holds fat will hold fluid. So you need to find an area that has fluid that doesn't have fat. So you look right here in the spinal column. This whole area that's lit up is cerebral spinal fluid. So there's no fat there. It's just fluid. So it's lit up. So you know it's T2. So that's a quick trick. And then PET scans, typically you're looking for some sort of metastasis, right? It can pick up metabolism, of, particularly of glucose. You know that tumors will like to, you know, their metabolism is kind of revved up. So you can look for these areas. So they use PET scans. Typically somebody already has cancer and they're looking for any sort of metastasis. So increased areas in the body of metabolism would be indicative of that. All right, so quickly, we kind of talked about this a little bit, but we want to go through these. So brainstem development, this is kind of a weird lecture, but what you need to know here is after the brainstem kind of forms itself properly, the alar area or the alar plate is going to be on the posterior aspect or the dorsal aspect, better terminology. So that'll be the sensory area, okay? The basal area is going to be the ventral area, and that's going to correlate to the motor. So if you know this, you already are ahead of the game, but that's going to correlate to how that lines up. All right, and then we have the different tracks. Cortico-bulbar, when you hear bulbar, you want to think of face. Corticospinal means it's going from the brain through the spinal cord. So it's like a motor cortex, right? Cortical to the spinal area or to the muscle. So brain has to tell the muscle what to do. So these are going to be muscular tracts. We're going to talk about those later. The reticular formation, if this comes up, it's very primitive. It has to do with automatic movements, stuff like yawning, sleeping, even eye movements, but it kind of runs this little length. The area postrema is also in there. It's your vomiting center. So if you have some sort of hydrocephalus, and you get some sort of pressure here through this canal where the ventricle fluid, the CSF travels, you can get nausea, vomiting, and stuff like that, problems with swallowing, respiration. So very primitive aspects that are automatically controlled in the body, reticular formation. Okay, we talked about this again. This is the one thing you're going to want to draw out. Let's go through it again. What are we looking at? Is it the carotid pathway or is it the vertebral pathway? Well, we can see that central basilar artery. Okay, so it's going to be the vertebral pathway. So we're going to give blood to the posterior aspect of the brain primarily. Now this actually lies on the anterior surface of the brainstem. Okay, so you can correlate it like that. You're kind of like looking at the patient if the patient was lying, you know, face up, right? So this is the anterior aspect. So we have our two vertebral arteries. Remember, we said the pica comes off of the vertebral separately. Then the vertebrals join together to make the basilar. At the base of the basilar artery, we have that ica coming off, right? So there's the anterior and then the posterior comes off. So vertebral to the posterior, basilar, then the ica comes off the anterior inferior. And then as you travel up the brainstem, the superior cerebellar comes off, and then that final large branch point is going to be the posterior cerebral, right? And then you have the circle of Willis that comes together that will connect this vertebral system to the carotid system. The carotid system will lead to the middle cerebral artery, and then it will connect through this anterior communicating artery to this to the anterior cerebral artery. So be able to walk through this and know where everything is. And again, let's look at this. So when we talk about specific lesions, we're making it clinical, right? So if there's some sort of aneurysm or some sort of pressure that's pressing on these different junction points or these specific vessels, these are the cranial nerves that will be affected, right? So posterior cerebral, we're very high up in the brainstem. We're thinking cranial nerve 3 and 4. If it's the ica, right, coming off of the basilar, we're thinking maybe 5, 6, but usually it'll be 7 and 8, right? Some sort of facial and vestibular cochlear problem. And then if you're looking at the pica, which comes off of one of the vertebrals, it's going to be the lower cranial nerves, 9, 10, 11, or 12. Okay, difficulty swallowing, stuff like that. So just knowing this right here, you'll be able to answer questions, I promise. They're gonna give you symptoms of cranial nerve problems, and they're gonna ask you which artery is affected. Okay, so just kind of work through that on your own. Cerebellum, again, y'all will talk about this later. It's just, it kind of fine tunes all the movements, right? It's where your body is in space. Like if you can close your eyes and you can kind of tell where you are, where your arms are located. It's just a fine movement area of the brain that it helps with fine movement, put it that way. So you'll see certain problems that have to do with the cerebellum have to do with these fine motor tasks. But again, y'all will get into that a little later. So if we break it down, again, remember cranial nerves 1 and 2 from the brain, 3 and 4 at midbrain, 5, 6, 7, 8, pons, 9, 10, 11, 12, medulla, okay? The ones that are medial are going to be are going to be solely motor. The only weird one, cranial nerve 4 actually comes from the posterior aspect of the brainstem and wraps around. You could see it wrapping around here. Other than that, all the rest of the insertion points are visible, okay? So like 6 and then 7 and 8 travel together. 9 and 10 kind of travel together. 11 spinal accessory is kind of a weird one. And then 12 being primarily motor is centralized. So maybe drawing this out will help you do it. But one more time, this is going to be a big NB2 topic. Right, so again, we talked about this anterior fossa versus middle fossa versus posterior fossa, kind of where everything comes out in the skull. All right, so general concepts, we're gonna do the tracks later, but remember that sensory fibers have a 3 nerve pathway, okay? They're gonna have to relay through the thalamus. So remember, the thalamus is a relay center. It helps to orient the sensory system to kind of tell it where to go. So there's gonna be a primary neuron to the brainstem. Then there's, it depends, sorry. So it depends, we're gonna get into this, the ALS versus the DCML. But either way, if it's sensory, it's gonna have 3 nerves that are traveling from the site of sensation to the brain, because the tertiary nerve has to go through the thalamus, from the thalamus to the brain. All right, but I'll point that out again later. Whereas the motor cortex is a 2 nerve system, right? It's gonna have a lower motor neuron to the nuclei. Here, the cranial nuclei is what's depicted, but you're going to have a lower motor neuron, and then in the CNS you'll have upper motor neuron, but we'll talk about that a little later. So let's talk about the different hemorrhages, right? So this will help you orient yourself to where things are. The thing I want to point out here is that when you talk about subarachnoid hemorrhages, the reason that they're subarachnoid is because these cerebral arteries travel between the arachnoid and the pia. Okay, whereas when we look at subdural, they're going to travel between the dura and the arachnoid. Okay, and when you talk about epidural, they're going to travel between the dura and the periosteum, or the bone. So we'll break these down, and we'll talk about how they go. So here's the situation. So epidural hemorrhage, guys playing sports, gets hit on the side of the head, right? He goes down, he's unconscious for a second, then he gets up. He feels fine. This is considered called the lucid interval. He's like, I'm good, everything's fine. Then an hour or 2 later, he just drops, okay? So let's go through the process here. He gets hit immediately. You rupture the middle meningeal artery. Now, it's an artery, so it's a high pressure system. Now, because it's high pressure, it has the ability to push the brain to the side like that. So he gets knocked out, ruptures the middle meningeal artery, then he feels fine. So that lucid interval allows time for this artery to sort of push the brain out of the way. Now, the brain doesn't have sensory fibers, right? So you can't really tell, but eventually it's going to push the brain so far out of the way that the brain's going to herniate through the foramen magnum, right? You'll get that uncle herniation, and then he's going to drop, right? So that's the situation that we're talking about here. This is considered a biconvex disc. Why is it like that? Because the artery is a high pressure system. It has the ability to push the brain out of the way. So one of the important points, because it is epidural, epi meaning outside of the dura, it's between the dura and the periosteum, okay? So it's between the dura and the bone. Because of that, it can't cross the suture lines, okay? So those suture lines are going to separate the different aspects of the brain, but because it's limited to one area of the bone, one specific bone, it can't cross the suture line. So they could specifically say that there's some sort of hemorrhage in the brain. You're looking at the CT here, right? Bone lights up white. You can see the fluid building up, but it doesn't cross the suture line, right? So you're looking at an epidural hematoma. All right, subdural. So here's the story. There's an elderly person. They fall. It may not be a traumatic fall, but they fall, something happens. Then about 3 weeks later, they start to see symptoms, right? They feel dizzy. They may have some memory loss, just sort of odd symptoms. And so what you see here is that because they're elderly, their brain starts to shrink, okay? So when the brain shrinks, there are bridging veins that connect the skull to the brain, right? So if the brain's shrinking, these bridging veins get longer. And when that happens and the patient falls, it can kind of shake the brain and it can tear these bridging veins, okay? Now, it's a vein, so it's not a high pressure system. So this is why it takes a while for these symptoms to develop. Now, because it's not a high pressure system, you don't see that same biconvex disc. You see this lens shape, right? Or this crescent shape, like a crescent moon, because it's a low pressure system. So again, it's going to take time to develop. Now, because it's subdural, it's going to be between the dura and the arachnoid. So subdural kind of gives it away, but what does that mean? That means it can cross the suture lines. Okay, you can see it all the way across. Remember, if we look at the epidural, it's limited by these sutures. This high pressure system is limited by the sutures. Look at how far this crescent shape goes. It's not limited. And that's because it's between the dura and the arachnoid. Okay. And as for the symptomology of this, it just kind of varies between patient to patient and, how bad this crescent shape ends up. But typically you're talking about an older person. You're talking about the bridging veins, talking about a few weeks before symptoms develop. Now, subarachnoid hemorrhage, this is really dangerous. Typically, you see it kind of centralized. Remember, we talked about that anterior communicating artery, how that high pressure blood from the carotid artery goes to that anterior communicating. And a lot of times that it can cause aneurysms. Now, if aneurysms rupture, remember we said that the cerebral artery travels between the arachnoid and the pia. So that's why it's subarachnoid. So this is where this blood's going to develop. One of the key features you'll see is you see blood start to pool in the sulci. Okay, so this is very bad. People with chronic high blood pressure, you can get this. Obviously, it could cause aneurysms. They talk about this. They say it's a thunderclap headache. Okay, so you're sitting there, all of a sudden it's like boom, hits you. Patient comes in and says, "This is the worst headache of my life." It's very common for that. It's kind of like when you have a heart attack and people say it feels like an elephant sitting on my chest, right? Same thing. They say this is the worst headache of my life. So you get a CT scan. You see the blood develop, subarachnoid. Hopefully you can go in surgically and sort of stop the bleeding and limit the aneurysm. Now, lastly is the intracerebral. So very similar to the subarachnoid, but here we're going to be dealing with small arteries, right? A lot of times these are watershed areas that don't get a lot of oxygen. So you'll see this blood develop here. These are less common, but remember these have to do with these smaller, these lenticular arteries that develop. So you could see this here, and these are going to be intracerebral, right? So even below the pia mater, okay? They're actually diving into the actual the blood. I'm sorry, the blood is actually diving into the actual tissue, okay? And you can see that here. Yep, sure.
Is this that imaging on the right? Is that a posterior lesion bleeding into the ventricles up above, or like how could you differentiate between like an anterior lesion versus like posterior? That's gonna.
Yeah, honestly, I would be guessing if I tried to do this. You can see, I would say maybe this area because there's more blood, but it does look like sort of like here. It looks like these small arteries are bleeding into the ventricles. And look, remember that C shape of the ventricles. That's why you see, this is just the cut we're looking at, but you can see this blood kind of pooling in the posterior aspect, right? So those C's, right? The C's coming kind of out of the screen back down, and that's why you see the blood pooling. But yeah, it looks like there's something here that's kind of bleeding into the CSF. So for instance, if a patient comes in, first of all, if a patient comes in with a headache, before you do some sort of lumbar puncture or spinal tap, you have to check them for some sort of hemorrhage in the brain. Because if you do a lumbar puncture and there's high pressure in the brain, it causes a lot of problems with the pressure gradient. But if you were to be able to get some sort of CSF, a spinal tap, you'd probably find, I'd imagine you'd find blood in it, right? Because it looks like it's bleeding into the ventricular system, yeah. But again, this versus a subarachnoid, you see the subarachnoid going into the sulci, right? You don't see that here. It's more diving directly into the ventricular system. Okay. So now let's talk about the blood supply that go from the different cerebral arteries. So remember, the middle cerebral is going to give blood supply primarily to the lateral aspect of the brain. The anterior cerebral is going to be the middle aspect. So this comes into play when we talk about that homunculus. So the middle cerebral artery is going to supply the vast majority of the homunculus, both motor and sensory. It's going to, including the arm, the face, but once you get, and the trunk, but once you get to the medial aspect, the leg is what we're talking about on the homunculus, and the leg and the genitals are going to be supplied by the anterior cerebral artery. So you will get questions that ask you, there's some sort of problem with somebody's left leg. So where's the bleed, or where's the problem? Where's the lesion? So if it's their left leg, it's the right region of the brain, medial brain, that's supplied by the anterior cerebral artery. Because remember, your left side controls your right side controls your left, right? So they talk about this in regards to the homunculus. I believe I have a picture coming up, but you can see this is the medial aspect of the brain, and this anterior cerebral artery is giving blood there to this limbic system. But you can see this is that leg genital region of the middle aspect of the brain. And then of course, the posterior cerebral is going to give blood to the occipital lobe and this lower aspect of the temporal lobe. All right, and then this is just a nice picture from first aid. Again, middle's kind of is on the outside. Posterior kind of gets that lower aspect and the posterior aspect, and anterior is going to be medial and most anterior as well. We kind of talked about this again. Remember, central sulcus, that's your mark you want to look for first. Primary motor versus somatosensory. It's going to divide the frontal from the parietal. And then there's some other concepts that y'all will get into later. These premotor cortex has to do with motor movement. I think I have a slide, actually. We'll just wait on that. So here's your homunculus, right? So we talked about the lateral aspect, primarily supplied by the middle cerebral artery. But once you get to this medial aspect, the anterior cerebral artery is going to supply the leg, the foot, the genitals, right? But for the most part, you need to know kind of where this lays, because they could ask you a picture and ask what part of the body is affected. So this is from first aid. This is the one I would go with. So remember, the face actually goes very far down, past even this division between the parietal and the temporal lobe. So the face is there, the arm is here, and the leg kind of goes, and the foot goes into this anterior cerebral artery. So what's interesting here is, like, you see how much space the face takes up. That's because for sensation, you have a lot of receptors in the face for sensation, right? You have a lot of receptors in your hand for sensation. Look how much that differs from the arm, the shoulder, and the neck, such as like 2-point discrimination, right? On your face, you can differentiate 2 different points, right? Whereas on your back, it may be more difficult. So the face is so large because it has increased receptors. Also, even in the motor area, you have so many muscles in your face, so it has to take up more space. Look how much motor movement and fine movement you have of your hand. That's why it's taking so much of the homunculus up, right? Because you have all of these little fine motor movements. You need more brain power for it, right? All right, and I'm bringing it up again, just for completeness sake. Remember, these break down, these arteries break down to different cranial nerves, and that'll help you locate the lesion. This is from first aid. This is a really good picture. So it kind of shows you how the posterior aspect, or the PCA, comes off of the vertebral, and then you have the MCA and the ACA coming off of the carotids, right? And you can appreciate that here as well. You can see the PCA comes from the vertebrals to the basilar, to the posterior aspect of the brain, and then you see these carotids come to the middle and the anterior aspect, and it's all color coded for you. And of course, the circle of Willis is what's connecting. Here's that anterior communicating artery. Remember, we talked about this high pressure system that goes into this smaller artery. So this is a place you worried for aneurysms or subarachnoid hemorrhage, and it can compress even on what you see here is this optic chiasm, right? This optic nerve. So you can give you some sort of visual field deficit. All right, so kind of walk through this. Again, this is a really good picture, kind of show everything. And I think this is the last thing I have before Lindsey's gonna do her lectures. So we're gonna look at this ventricular system. So remember, the CSF is secreted, or it's made by this here, these ependymal or ependymal, however you want to pronounce it, these cells here of the choroid. So this choroid plexus is going to start making this CSF, and these ependymal cells will help to make the lining between this, because there's a CSF blood barrier that helps to separate it, because obviously you don't want the CSF contaminated. So again, you have these two lateral ventricles. They go through the interventricular foramen, somewhere right about here. And then they go to this third ventricle. And then as you get to the brainstem, you have that long cerebral aqueduct that's going to go into the fourth ventricle and then down into the spinal column. Y'all will have a small group on this if y'all haven't already. So just knowing the flow of CSF will help you determine the different sorts of hydrocephalus. All right, again, same thing. We get the third ventricle, drops into the cerebral aqueduct around Mickey Mouse, and then we go down up the midbrain, and then we go down to the fourth ventricle. So you can appreciate kind of the flow there. And then again, the circulation kind of goes through. Remember, once it's pumped through the laterals to the interventricular foramen, to the third ventricle, to the cerebral aqueduct, to the fourth ventricle, then there's these foramens of Lucia or something like that. And then it's going to be recycled. So the point is, when you recycle it, it's actually sent back to the venous system. And what it goes through is called these arachnoid granulations. So once it gets into the venous system, it can be drained and then recycled. But that's an important point to know, these arachnoid granulations, because there's some pathology that has to do with these not being able to reabsorb or get rid of all that CSF. So this is from first aid. Again, you can kind of see the lateral ventricles go to the third ventricles, the interventricular foramen, also known as the foramen of Monroe. That's another name for it. Cerebral aqueduct, and there it is, yeah, the foramen of Magenti or Luschka, right? And then it goes to the spinal cord, and it could be recycled again through the arachnoid granulations that will get it into the venous system, right? This is the venous system we're talking about. It's good to be able to know these in relation to some sort of angiogram, okay? So be able to point these out on an angiogram. This is running sagittal, right, along the brain. So you have a superior, you have an inferior. All of these are going to drain into this confluence, right? Everything comes together, and then it's going to drain down into the jugular vein, right, to be recycled. But the arachnoid granulations are going to be up here, and they're going to drain into the sagittal sinus, the superior sagittal sinus, okay? And you can kind of see that here. This is a good picture. So all of the venous blood is going to come through here to this point. It's going to come all the way through here. And then from this point, it's going to drain out through the sigmoid sinus, through the skull down to the internal jugular vein, right? Oh, here you could see this, right? So you could see how everything drains. Okay, and then the different types of hydrocephalus. Remember, obstructive is the same thing as saying non-communicating. So a lot of times it'll be in that, between the what's it called?
Lateral.
Yeah, so yeah, I'm sorry, the cerebral aqueduct, right? So in between that tiny point, that long path through between the third ventricle and fourth ventricle, right? When it gets tight between the brainstem. So if you have some sort of obstructive hydrocephalus, it's going to be a high pressure hydrocephalus, right? It's going to be some sort of increased pressure in the brain. So you could see that. Communicating hydrocephalus, like normal pressure hydrocephalus, a lot of times that happens in geriatric patients because their brain shrinks, right? So you do have increased fluid. It's not increased pressure, but you have increased fluid because the brain is smaller. The fluid has to take up the space, okay? So be able to differentiate that. It's a normal pressure. Obviously, if you have an obstruction, it's a high pressure problem. But this normal pressure hydrocephalus is typically seen in elderly patients. Don't get that confused with hydrocephalus ex vacuo. This is similar. You do get some sort of brain atrophy, particularly expansion of the ventricles. So again, CSF is going to have to occupy the empty space. So that's what you're looking at there, but it's a normal pressure. When you talk about obstruction, then you're talking about a backup of pressure. And also we talked about those arachnoid granulations. If you're either making too much cerebral, the choroid plexus is making too much CSF, or you're not able to get the CSF out through the arachnoid granulations, you can get some sort of high pressure hydrocephalus as well. Okay, so do the questions with those. Yeah, we should take a break and then Lindsey can cover her material. So let's
Brady,
take,
I have a quick question.
Yeah.
Don't we have like two types of communicating hydrocephalus, like one with higher pressure and one with normal pressure?
Yeah, so the normal pressure is the communicating hydrocephalus. Any sort of normal pressure. When I think of normal pressure, I think of basically space occupying, right? So if the brain is atrophied because of age or because of some sort of pathology, the fluid has to take up the space. That's why it's normal pressure. Whenever there's some sort of non-communicating or obstructive, that's when you're dealing. Typically, a lot of times this will be in kids, right? And they'll have some sort of obstruction, and then that will lead to the high pressure system.
Okay, thank you.
All right,
wouldn't the secondary to subarachnoid also give you high pressure too? Because it's taking up the.
Yeah, and so it says yeah. So this would be, yeah. I believe this would be high pressure system too, or high pressure. It's still communicating because you don't have an obstruction, but yeah, that would be high pressure just because there's a lot of excess blood and CSF that's forming in the brain. Yeah, for sure. All right, we'll take a few minute breaks. Y'all, get some coffee.
Could I ask you a quick question?
Yeah, of course.
So when we were talking about the arteries, and we were talking about the I think one of our questions that you did say way back when we started this was the anterior communicating was one of the answer choices, but I think it was because it was a second. It was like the branch from the anterior cerebral. Was it the? Trying to think which cranial nerve it was trying to affect, because you said if there was like a lesion or like if pressure.
Yeah, typically, like if you look at right here, this anterior communicating, it'll put pressure. If there's some sort of aneurysm there, it'll put pressure on the optic chiasm. So you get some sort of sensory deficit in your eye. You get like blurry vision on the outer aspect of your eye. Yeah.
And that's 2, right?
Yeah, that's cranial nerve 2, right? So 2 is vision in, right? Sensory vision. 2 is going to be able to monitor the light coming in. 3, 4, and 6 are going to be your eye movements, so your motor movements. So yeah, with some sort of anterior communicating artery problem, you'll have problems with cranial nerve 2, which will be the vision. Now, don't get that confused with the uncal herniation. the uncus is by cranial nerve 3, right? So if it herniates through and you get an uncal herniation, you're going to have problems. Your eye will be deviated. So it's a motor problem. It's cranial nerve 3.
Cool, that makes sense. So like be on the lookout for essentially, I think as I said, anterior cerebral could have been a choice, but since it wasn't, you had to look for like the branch of it. And I guess that's the anterior communicating part.
Yeah, for sure. And I think because of the idea that it's such a smaller artery compared to the larger ones, that it's most commonly injured in sort of, because it has to go from that high pressure system to that kind of small communicating artery, that side road. So it has a lot to do with that high pressure system. Yeah.
And the cerebral spinal fluid, that's made in the epidermal cells. But is that like just on the outside of the, what was that, the ventricles or the?
No, I'm pretty sure. So the CSF is made by the choroid plexus. I think.
Yeah.
Okay.
Yeah. So the epidermal cells are like the lining of the choroid plexus. It kind of separates it's the CSF blood barrier. And so CSF could kind of go through. I do believe there's like 2 types of epidermal cells. I can't really.
I'll be going over that.
All right,
Okay,
cool. Yeah.
sorry.
So
Yeah.
Lindsey
All right,
will
I'm gonna
cover
go.
it. Yeah,
I'll
no
chill.
worries. No worries. No worries. Yeah. Yeah.
Okay, are we ready to get going, guys? Yeah, he's gonna finish his slides after mine. So we're giving him a little break. Okay, I'm gonna go ahead and get going.
Where are your slides posted exactly?
I put them on my Facebook page. I tried to put it in the Zoom chat, but I can't figure out how to do it.
Okay, no worries. I'll look it up.
Because I made it into a PDF. So I don't know how to put it in there. I think they changed something, whatever. But they're on my page, DogMomD. Yes, it's a PDF. And we will put that together when we post all of the resources later with the recording. But we are going to start off with neurons and glial cells. I tried to condense this as much as possible. I rearranged some of the lecture slides to put it in, because I love chunking information. And so I'll go through my lectures and I'll actually put pieces of information together if it relates. So that's what I did for you guys. So neurons and glia. I condensed this down. Neurons, of course, they're excitable cells. You do it for signaling. Cytoskeleton, the biggest thing here is knowing the difference between neurofilaments and microfilaments. So neurofilaments are going to determine diameter and it gives mass to the axons, and the microfilaments mediate growth cone during repair. You have multiple examples of this in your IMCQs, but this is one of those, it's an easy point if you get it, but if you don't know it, you don't know it. So make sure you do know it. Transport, kinesin is anterograde and dynein is retrograde. Types, you need to know the types and where they are located. Multipolar neurons are more going to be in central. Bipolar are going to be the special senses. So anytime you have something that is talking about smell, taste, these are your special senses. And if it asks for the type of neuron, it's a bipolar neuron. So make sure you understand that. And then pseudo unipolar are going to be in the peripheral nervous system, cranial nerve ganglia, and the spinal reflexes. So if you have an excitatory neuron, it's going to cause depolarization. Inhibitory, it's going to cause hyperpolarization. Now, the glial cells are the supportive cells. So neurons are what is actually doing the talking to each other from the brain to the rest of the body. The glial cells are going to support the neurons. So they're not excitable. You have 4 main types, the astrocytes. These are going to be located in the brain and spinal cord. Their big thing is to regulate the chemical content of the extracellular fluid. So the biggest thing here is it's going to kind of control the neurotransmitter in that synaptic cleft. And so it's going to make sure the neurotransmitter stays there, because if you, of course, have neurotransmitter dissipating out into the ECF, you're not going to get an action potential, you're not going to get the desired effect. And it can also reuptake and recycle it. And we'll talk a lot about that when we get to neurotransmitter metabolism. But the big thing there are the astrocytes. They play a very important role in that. Oligodendrocytes, make sure you know the difference between oligodendrocytes and Schwann cells. Oligodendrocytes, of course, myelinate neurons in the CNS. Schwann cells are going to myelinate neurons in the PNS. Microglia, these are the macrophages of the CNS, so they're going to survey and phagocytose any foreign material. The ependymal cells, we were just talking about this a little bit during the break. So you have group 1 and group 2 ependymal cells. Group 1 have the tight junctions and they only allow for transcellular movement. And so these are the big cells in the choroid plexus. And the reason these are the big cells is because they are going to be the secretory cells. So any water, any solute that passes from the blood into the CNS, into the CSF, is going to go through these type 1 ependymal cells. And then group 2 are going to be that they are going to have gap junctions, which means they are going to allow for paracellular flow. So remember, transcellular is through the cell, paracellular is in between two cells. And this is going to allow for exchange between CSF and interstitial fluid. And these are going to line the ventricles. They're ciliated. They help propel the CSF throughout the ventricular system because you'll know that there is a whole system of ventricles and you need flow of the CSF through that ventricular system, or else you get this isn't going to be associated with your hydrocephalus, but you know the importance of the flow of CSF through the system. But that's what those do. I put this on here for completeness sake because this is a big mechanism of the astrocytes, but honestly, the biggest thing you need to understand is that they do regulate the neurotransmitters and the chemical concentrations of the area. So I do not remember this being a huge thing on the, this particular thing being a huge thing. It's mainly, can you tell the difference between all of the different glial cells if you just have a basic definition. This is blocking it. Okay, so regeneration and degeneration of axons, I'm pretty sure they go into this in a lot more detail in later lectures, but do know the terms. So you have retrograde and then anterograde degeneration. You need to know the difference between those two. So retrograde degeneration, you are, so this is degeneration before the site of injury, and it's because these signals are not getting to this neuron, and so you can't, so it's effectively not working anymore. And then of course, anterograde transneural degeneration. Yes, please know the term. This is because, of course, you had the site of injury and then everything past it, you are not getting any signaling. And so it's essentially going to die off because there's nothing happening. So Wallerian degeneration, distal to the axonal transection, know the term Wallerian degeneration. That's important. And then, so yeah, you guys go into this a little more detail later on, so I'm not going to hit that too hard here, but do know the terms. That's what I want you guys to understand. Please know the terms. Clinical correlates, I put this here for completion's sake. Again, I gave you guys that link to my Google Drive that has the diseases, and I put all of the information for all of the diseases into one document. But you do need to know the difference between multiple sclerosis and Guillain-Barré. These two are fairly similar. So autoimmune demyelinating disease of the CNS versus inflammatory demyelinating disease of the PNS. You need to be able to distinguish the two of these based on clinical presentation. This is very important. And so the big thing, you have muscle weakness in multiple sclerosis, and Guillain-Barré, you are going to see symmetrical ascending paralysis. So it's going to start in the feet and it's going to go up, but it's going to go up at the same rate and it's going to go up together. So that's a big thing of Guillain-Barré syndrome. But please know the difference between the two of these based off of their clinical presentation. Okay. So neurons and glials, that's pretty straightforward. Now we're going to touch on excitable cells. So the something you'll probably have maybe 1 or 2 questions on this. This is the length constant. I condensed this into one slide because this is basically the gist you need to know. This equation at the top is what you need to understand mathematically to know how it's going to be affected by different things. So RM is transmembrane resistance. RI is intracellular resistance. And basically the definition is just the distance over which a graded potential decays. So if it's a large constant, you have less decrement, essentially meaning that you aren't going to lose the potential as fast over a certain amount of distance. So that's the biggest thing. So if you have a short length constant, that means you're going to have a high intracellular resistance and a low transmembrane resistance. If the length constant is large, it's going to be the opposite. And you can just know that mathematically by doing your fractions. If you have a higher number on the bottom, you're going to have a lower number as your result, and so short length constant, but be able to know the difference between these if they give you or they'll tell you either short or large length constant, and you need to know what factors have been altered to get either the short or the large length constant. But that's just
were you guys given values and having to calculate this?
No.
Okay, thank you.
It's conceptual. And then action potential, the big thing on this slide, I put a lot of my whiteboarding pictures on here because I simplified it a lot. The 2 biggest points of information on the slide are actually in this whiteboarding picture. The axon hillock is where you get the site of an action potential, so you get impulse activation. And then the dendrites are the graded potential. So input integration, you get graded potentials. If you do not get to the threshold, you do not get an action potential. And so you can, how do I do? Oh, pointer, cool. Oh, wow. So in these dendrites, you can have multiple graded potentials and it keeps going and keeps going and keeps going and keeps going. But if this is all sub-threshold, you're not going to get an action potential. But as soon as you get to threshold, this axon hillock right here is the thing that actually senses it. And that's what gives you the action potential. So 2 possible questions are going to come out of this slide. It's the difference between graded and an actual impulse activation. Okay, I condensed all of this because I spent a lot of time doing this on my whiteboard. Like I said, I put a lot of whiteboard pictures in here for you guys because I condensed like 4 or 5 slides into one because it made sense to me. So this is the voltage gated sodium channel, the NAV. This is the structure of the NAV right here. So you see you have 4 little groupings, and all of these have different transmembrane domains. The 4th little domain here, this is what is going to be voltage sensitive, but the money is right here between D3 and D4. So this region right here, you have the IFMT. This stands for isoleucine, phenylalanine, methionine, and threonine. These are, of course, amino acids. So when these get pushed out, the S4, that's what this is talking about, with all my little plus signs. When it's activated, these get pushed out. And so these amino acids are going to link together and bind to the D3, D4 link. And when it binds, you inactivate it and the gate blocks the ion flow. That's the mechanism right here. And so this is that inactivation gate. So you'll see the linking right here between S4 and S5. And then when these get pushed out, these get exposed, and then these are going to link, and you have the inactivation gate right there. So I tried to put it all on there for you guys. But prior to that, so when you get depolarized, that's just what I was talking about. So you have depolarization. These positive amino acids are pushed out due to the intracellular positive, because it gets positive on the inside because you get depolarization. Sorry, I'm talking in circles right now and I apologize. But then it gets pushed out because these are all positive. And then when it opens back up, you get the activation gate. So did that make sense? Do I need to go like step 1, step 2, step 3? Because I feel like I just talked in a circle. Okay, nobody's saying yes or no, so I'm going to move on. Now you can have pH interfere with this. Okay, cool. Thank you, guys. You can have pH interfere with this because the hydrogen ions are going to interfere with the sodium access to the pore. So this is all in a circle. Like this is drawn out very linearly. This is going to be in a circle. So if you decrease pH, so example, exercise, heart ischemia, different drugs such as cocaine, this can trigger symptoms of electric disease in patients that have mutations, NAV mutations. That's what mutes means. But this actually wasn't very big on our exam. I'm not gonna lie. They might put it on your exam. If they do, I would assume 1 or 2 questions. So I wouldn't hit this as hard as I did right here, drawing it out as intricately, but just know the general mechanism of this. And the big thing, these are concentrated at the nodes of Ranvier, which we're going to talk about in the hot sec. You should know what the nodes of Ranvier are because I think they start teaching you guys this in like high school, middle school. But so just continuing at the NAV, you can have local anesthetics effect on this. So it's going to bind to the open pore and prevent the return back. So it's going to open up and it's not going to let it close back up. So what happens is you're effectively blocking the firing neurons when you have the open channels. So this is called preferential binding or preferential blocking. So when you have a neuron that's firing, you're getting these action potentials down. So which means on the inside here, we're going to say this is intracellular. Intracellular here, you get an influx of sodium, which means a positive charge. It opens this up because the positive amino acids are repelled by the positive sodium in here. It's going to open this up. So that means these are available for this preferential blocking. So it's a firing neuron, preferential blocking. Lidocaine comes in and it blocks it. It blocks any subsequent firing because it can't close and kind of reset itself. So that's what that is talking about. So it's also called use dependent. This is basically saying the same thing. It's just adding on. So use dependent, meaning as you use the firing neurons or you use the neurons they're firing, that means it blocks it. Saltatory conduction, this just is associated with the myelinated versus non-myelinated. You know that myelinated neurons are going to conduct an action potential a lot faster. This is because of the saltatory conduction, which essentially means the action potential is going to jump from node to node to node to node. And the sodium, voltage-gated sodium channels are going to be localized in these nodes of Ranvier. So that's essentially what we just talked about there, but for completion's sake. Myelination, this wasn't a huge thing. Brady, correct me if I'm wrong. I put this here for completion's sake, and I do remember drawing this out, but I don't remember this being a huge thing on the exam.
Yeah, I think just knowing that those pain nociceptive fibers, the C fibers, are really slow. They're not myelinated. They're really slow fibers. So you could just differentiate the speed by the size and degree of myelination.
Yeah. Yeah, the nociceptors. That was the big thing here. Demyelination disorders, we kind of talked about some of the named ones above, Guillain-Barré, but these, of course, lead to a destruction of the myelin sheath in some form or fashion. So this means that you're going to have a very slow action potential or a blocking of the action potential. Again, the big ones are going to be Guillain-Barré and then myasthenia gravis. So those are the two that I would focus on the most. Now we're going to talk about transport in the CNS. So CSF functions, this isn't a huge thing. I put this on here just to highlight the cerebral perfusion pressure. I added some notes on these slides that I wrote down from lecture. So if the MAP, mean arterial pressure, increases in the body, you can decrease the CSF production to stabilize the cerebral perfusion pressure, because you know CSF, you have a pressure that is within normal limits. And if you get higher than that, that is diagnostic, or it's suggestive of some kind of pathology. And you never want to have an increased ICP, intracranial pressure, because of course the skull is a very finite structure and there's not a lot of movement. And so if you get in a high ICP because of increased CSF, then that can cause a lot of stuff. The biggest thing here, they probably talked about this in your lecture as well, protein and glucose content are diagnostic for CSF. So this should be within a very narrow range. And so if these are changed, then that's diagnostic. And there's a slide later on where I point out some specific diseases that you should probably look at for this. But the rest of this, you don't really need to know. It's just protein and glucose. So I kind of already talked about this. So pathological elevation of the ICP, it's hydrocephalus, and 15 millimeters of mercury. I don't think you need to know the number of that, but if you do get an increase in ICP, these are some of the symptoms that can point you into that direction. Namely, papilledema is the big one you'll see with increased ICP. Blood-brain barrier, the biggest thing, you have tight junctions, no fenestrations. The astrocytes will kind of surround this. So the biggest thing is just knowing the characteristics of the blood-brain barrier. This was, I'm pretty sure you've had this in your ESOL quizzes, in your IMCQs. The biggest thing here, and and if they did for you, they did for us, they spent a lot of time talking about this slide in great detail, each individual molecule. The biggest thing here, you need to know how to interpret this. So if they're going to give you this right here, and maybe they only put a few on here, but you need to understand what this means. That is the big thing. Just understand how to read it, understand what this means. Essentially, they're saying how easily is this going to cross the blood-brain barrier, and do you understand? So glucose and L-DOPA are very freely going to cross the blood-brain barrier, because, I mean, glucose has your glutes, and then L-DOPA, forget which one it is, but just I put this on here just so you know how they are going to test it. And you've probably seen these MCQs in your quizzes so far, but that's how they're going to test it. The circumventricular organs, these are the organs that are going to sense changes in either the blood pressure or osmolarity. You're going to hit this super hard. They might not test it super hard, but you understand it a little better in NB2 when you start talking about NB2 or NB3. I don't remember which one, but just understand that they are going to sense small changes in your content, CSF content, and blood pressure, any of those changes. So the definition is a region where capillary endothelial cells lack tight junctions. So that's why they're going to be able to sense these changes, because normally the blood-brain barrier, you have the tight junctions, nothing can get through, and it's very highly regulated, very tightly regulated. So this is the ependymal cells again, so lining ventricles versus the choroid plexus. Remember that the tight junctions, this is the group 1, if I'm not mistaken. You can correct me if I'm wrong. Group 2 is lining the ventricles, but just understand the gap versus the tight junctions. And we've talked about that and what that means for fluid flow. And then we briefly talked about this. CSF is absorbed by the arachnoid villi. Please remember that. And these are little one-way valves in the dura mater. So you have the dura mater and you have the subarachnoid space. You can, superior sagittal sinus is a big one. Please remember this one. I don't know if we've talked about it yet, but that's a really big sinus in your brain. But arachnoid villi, please remember that. This is the chart I referenced. I looked at this more intently than I thought I should have, and there was a question on it, and I got it right simply because I looked at it for 5 minutes and just remembered writing down a certain thing. So these are all focus in on the infections. So if you look here, viral meningitis versus tubercular versus bacterial. So glucose is normal in viral meningitis, but you're going to see increased lymphocytes. Don't hone in on white blood cells. Don't hone in on WBCs. Hone in on lymphocytes. And then tubercular meningitis, you have decreased glucose with lymphocytes, and then bacterial, you have decreased glucose with PMNs. Polymorphonuclear leukocytes. So please understand that difference. So if you get a question or two on the exam, it is, it's easy. Okay, we talked about, you guys are asking about hydrocephalus. I copied and pasted this from my NB1 diseases document that I posted in the chat. Again, I condensed all of the information for communicating into this information because there is kind of, I put the different subcategories in here. That's what I'm trying to say. So communicating, you have an impaired or blocked CSF absorption owing to a thickening of the arachnoid villi. So this isn't an obstruction where you can't go from point A to point B. It's just in decreasing the space with which you can absorb and get it in there. And so it's not, yeah, stenosis. Thank you. That's a good word. And so you are going to have an increase. ICP results in diffuse ventricular dilatation. And so if you see, I have a picture in a slide or two, but that's the big thing. It's just diffuse ventricular dilatation. And this is because of that stenosis, and you're getting the backup. So hydrocephalus ex vacuo, this is caused by atrophy of the brain. And CSF is going to fill that space. And have you heard of, if you go in and you take out part of the brain, CSF is then going to fill in the part of the brain that was surgically removed? That's the same concept here. You have an empty space and the body says, oh, hey, we need to fill it with something. So it's going to fill it with CSF. So atrophy due to aging, or there are other conditions, example, Huntington's disease, that can result in brain atrophy. CSF fills, causes expansion of the ventricles. This is something that you're going to learn a little later on with respect to this disease. But you have normal ICP. Why do you have normal ICP? Well, you're not necessarily impeding anything. You're just increasing CSF because there's a decrease in other matter in the area. So you're not going to increase the intracranial pressure because there's no net increase of matter in the area. You're just increasing one and decreasing the other. So normal ICP. Now, normal pressure hydrocephalus, this is episodic. That's very key for normal pressure hydrocephalus. It's very episodic increase in ICP. Now, if you have continuous exposure to high ICP, it can lead to brain damage. But this presents mainly in the elderly, and it can be confused with Alzheimer's. I apologize if this isn't all in this, but remember I pulled all of this information into the same document. and then presents with memory loss, incontinence, decreased movement in the bilateral lower extremities, and then non-communicating. This is when you actually have a block, and so it's called obstructive. So it's not able to reach the subarachnoid space due to obstruction of, and these are just examples here. And then these are, you can result from an accumulation of pathogen immune cells. So this is a kind of an immune block there. Congenital stenosis, that's kind of a mechanical block or a tumor. So congenital is obstruction of cerebral aqueduct. And then secondary, this is if you have, I think I remember Brady saying something about this. If I might be mistaken, but this is a patient who had a previous hemorrhage, and then it's like you come back, it's reflexive, and you have blood clots that are blocking the passage of CSF. So it's kind of it's a sequelae of the initial intracerebral hemorrhage. And then, okay, so this is just a, I don't know if I got this from the lecture or if I made this up on my own for an example, but that's an example of what you would see with secondary obstructive hydrocephalus. It's just a sequelae of the original thing. Now I put all the pictures in here. So this is going to be your obstructive. So it's just at different points, you're going to see blockage of flow. So you have lateral ventricles, you see the blockage of the lateral ventricle here. This would cause buildup on one side. So you notice that this is expanding just this third lateral ventricle, not the other one. And then this is a cerebral aqueduct. So you're going to have expansion of both lateral and the third ventricle. And so you see here the non-communicating hydrocephalus. This is the congenital one, which we already said was an obstruction of the cerebral aqueduct. Communicating, remember this one, we're not impeding flow, it's just a stenosis that is resulting in lack of absorption or something causing that. So hydrocephalus ex vacuo, I would be able to look at these and understand what is going on here. So remember we said this is a diffuse ventricular hypertrophy. So you, on this rightmost picture, you see I believe that's the lateral ventricle or the third ventricle now. But it's just diffuse ventricular hypertrophy. And then normal pressure. Remember, this is episodic. That's the biggest thing. Normal pressure is just episodic. Now we talk about the edema. This I took from the blue slides and incorporated the chart. And so you have vasogenic versus cytotoxic. So with vasogenic, you have actual damage to the blood-brain barrier following trauma or inflammation. And this is going to allow for a fluid accumulation. And you can also see tumors. Cytotoxic, you disrupt the blood supply to the neurons in the glia. So you don't have enough oxygen and glucose, lack of ATP. If you don't have ATP, your sodium potassium ATPase doesn't work. And so your ion gradient are going to be messed up, and you're going to get damage from the subsequent swelling of the cells. So these are your symptoms. It just gets worse if it's not treated. And then osmotherapy is going to be the treatment for both. Neurodevelopment. I made a little sheet. This is primarily what I was talking about when I said I had to condense all of the information for lectures that were a little more wordy. This is that. So in the embryonic state, there is polyneural innervation of the NMJ, and synaptic elimination is going to convert it to mononeuronal. And this is called synaptic pruning. I believe that's what Minnelini called it, synaptic pruning. But the retraction of the loser neurons subsequently die due to failure to compete for chemicals for the target. And this, I like charts, I like flow charts. And so So embryologically, you have the neural plate, which is you're going to get neural crest and the neural tube. Neural crest, of course, you get components of the peripheral nervous system. Neural tube, you're going to get components of the central nervous system. So I just put that in there for you because I like seeing it visually. So induction. This is the process by which embryonic cells in the ectoderm make the decision to, they're like, okay, yes, we're going to form the neural plate. The reason this happens is because you have BMP and you are going to negate BMP, which means the ectodermal cells are not going to form the neural plate. So cordon and noggin from Henson's node is associated with this. And then the neural plate is just a thickening of the ectoderm. That's the definition of the neural plate. This is just a point I made for myself that you get the neural groove and then you get the neural tube. And then neutrophins, you've probably seen a couple questions in either IMCQs or the ESOF quizzes over the neutrophins. This is just a family of proteins that induce survival and help in the development of the function of neurons. And so they're actually provided by the neurons themselves and then by mesenchymal tissue through which the axons are actually growing. So in the peripheral nervous system, you have nerve growth factor. In the central nervous system, you have brain-derived neurotrophic factor. And then NT3, I believe this is the main one there. Segmentation. This is when you go from 3 segments to 5, so prosencephalon, mesencephalon, and the rhombencephalon. And then you get what we understand as the telencephalon, diencephalon, mes, met, and myelencephalon. So that's what segmentation is. And the biggest thing, and I'm pretty sure he said this on like 4 slides because he really wanted you guys to hone in on it. So I just put it on 1 slide. He gets really excited about this, but it's due to the homeobox genes, that's what segmentation is. And then the differentiation is based on the expression of these genes, and the expression is determined by the longitudinal gradient of the retinoic acid. So he really hones in on that point. Something that can interfere with this gradient are the acne meds, isotretinoin. That is, oh crap, what's the name of that one?
Accutane?
Yeah, Accutane. They make you take a pregnancy test if you're going to do Accutane because it can interfere with us and you can get all sorts of bad defects in spontaneous abortion. I'm pretty sure there was a question about that on the exam. Then the hindbrain segmentation, you have the rhombomeres, and there are 8 rhombomeres. So neurons within each rhombomere will form clusters of cell bodies, which these are axons for the cranial nerves, and they all have specific genes that influence the postnatal rhythmic patterns. And then I have pictures, I pulled it in from the lecture, but as the neural plate is folding into the neural tube, BPM47 from the ectoderm promotes dorsalization. So you need to understand BMP47 is dorsalization. Sonic hedgehog or SHH is from the notochord, and it's ventralization. You need to know the difference between the 2 of those. And then once it's folded, BMP47 is going to be from the roof plate, and SHH is from the foreplate. So it's continuing to promote formation of dorsal sensory neurons and ventral neurons. So it's folding over, and I put the pictures in here. So this is the segmentation. Remember, it's the homeobox genes, which are going to determine the segmentation. These EMX leading to schizencephaly. I'm not sure if this is the association that they focus in on with schizencephaly, but it would be good for you to understand which would be associated with which pathology. And then this picture for schizencephaly, I would understand that that's what this is and understand what it is. And then segmentation, this is what we were just talking about. So you have the BMPs, this is promoting ventralization, And then this is the notochord, which is secreting the SHH. And this is promoting ventralization. And so it will then fold on top of each other and get your final product. So this is for kind of completion's sake. And then you have cell maturation. So we've kind of done the spinal cord here. We've formed the nervous system. So now we're talking about maturation. So we're actually getting neurons going out into the periphery. So you have the growth cone, which is a large actin-supported extension of developing or regenerating neurite. And so how do developing motor neurons find their way outside of the CNS? I apologize. This is kind of long-winded, but the slide, there are like 3 slides and I spent so much time trying to decipher these. So this is probably long-winded and I apologize for that. But if you're trying to go through it, this may help you, this may not help you, but I put my notes in here in case in case it can help guide you through those slides. There's probably one question on this stuff, but I will go over, okay, I didn't put that picture in there, okay. But, so the growth cone moves and you have long range and you have short range chemicals. So as the growth cone gets, so floor plate of developing spinal cord secretes the Netrin 1. So we talked about that floor plate. So that's secreting Netrin 1. That's a long range attractant, which means that something far away can be attracted to it. So the growth cone is going to move towards it. As it gets closer, it's going to lose the receptors for the Netrin. It's going to gain other receptors that are more short range, and it's going to keep it near the midline. And then you have a repellent that kind of makes it cross the midline. And so because it can send it out of the CNS to its ventral organ, something to understand. Antibodies, it's ABS, antibodies to TAG1, and then NERCAM can cause their neuron to stay ipsilateral. So this crossing of the midline will cause the contralateral. And then if you have antibodies to it, it'll stay ipsilateral. And then critical periods, this is just a definition, windows in early life where neuronal circuitry is restructured in response to experience. He gives a couple examples in the lecture, namely the vision ones, because all of them are crossed, but then once an infant starts using its vision, then it gets restructured to what it will be later in life. Synaptic transmission, there are 3 types of synapses. So you have electrical, so these are synchronized electrical activity between cells. These have gap junctions. So this synchronization is done via gap junctions, voltage sensitive, passing ions between the cells, intercellular communication. Chemical, this is the big thing with the nervous system, or with neurotransmitters. So these are the most common. So presynaptic cells are going to secrete the chemicals, so neurotransmitters, and then the synaptic functions can be mediated. So we'll talk a little bit about that. Ionotropic versus metabotropic, you need to know the difference between the two. Essentially, ionotropic, you are going to see an ion flex. Metabotropic is going to signal metabolic changes. So these are your G proteins, G coupled proteins, and it's going to be slower. Tripartite, all this is talking about is 3 cells interacting, and what we're adding is a glial cell, and we're going to talk about that when we talk about neurotransmitter signaling and metabolism. Neurotransmitter synthesis, small versus large molecules. Small molecules, which we're talking about as amino acids and gases, these are synthesized in the cytosol and packaged in the vesicles. And you know, we've talked a lot, or you've talked a lot probably in your education up to this point, you know, vesicular trafficking, and then the vesicles are going to bind and they release into the synapse. That's what that's talking about. Versus a large molecule, it's a propeptide synthesized in the somata. that's the difference here, synthesis in the stomata versus synthesis in the cytosol. These are packaged in vesicles, again, vesicular trafficking, but it can also be cleaved into smaller peptide neurotransmitters. And that's what happens a lot with these, what we're going to talk about later in this review. So as actopotentials arrive at the end plate, you get activation of the calcium, which and then the subsequent influx are going to promote fusion of the vesicles, then release into the synapse. And then, of course, the neurotransmitters are going to diffuse across and do what it wants to do. Quantal stuff, you need to know the difference between these two. Quantal size is just the smallest postsynaptic response neurotransmitter release from one vesicle versus, so it's just the size of the what's coming out from one vesicle. Now quantal content, so the content is going to be a little more overall, so it's the number of vesicles that are going to be released due to an action potential. And then one single vesicle is going to produce a mini end plate potential. Each individual will increase it. So there's a chart in your little graph in your thing. It looks pretty much exactly like this, but you have one mini EPP versus stomata is a cell body versus multiple. This is all of those things that can affect the end plate. So first, you can block the sodium channels on the axon. This means that you're going to get less action potentials, because if you are interfering with sodium channels, you are interfering with its ability to depolarize. And so you're going to get less action potentials. And of course, if you have less action potentials in the axon, you're not going to have neurotransmitter release, so decreased neurotransmitters. Now, you know that once an action potential comes down here, you get calcium release that is going to facilitate vesicular movement, docking right here, and then release into the synapse. So if you inhibit the calcium right here, you are going to inhibit neurotransmitter release. Now, it's not going to affect action potentials at all, because remember, we already had the action potential. The action potential came down the axon. We're in the synaptic bulb right now. And so you have the action potential, but you can't do the neurotransmitter release because calcium is what facilitates that neurotransmitter release via the vesicles. So something that we're going to talk about in a moment is Lambert-Eaton syndrome, which are autoantibodies against this calcium channel, but we're going to talk about that in a moment. There's a whole slide for it. Some things that can directly act on the vesicle here. I'm sorry, this is kind of to the side. You have beta bungalowtoxin and you have tetanus. And so these are going to act on different aspects of the vesicle binding right here to either prevent, or I believe one of them like increases vesicle release, but it's going to have that effect. Botulinum is also another one that interferes with protein vesicular release. Now, when we get away from this presynaptic area, now in the actual synapse, you can inhibit acetylcholinesterase. And you know, acetylcholinesterase is responsible for the metabolism of the released acetylcholine. And so if you don't metabolize it, you have increased acetylcholine, so you can get increased action potentials in the postsynaptic neuron. So neostigmine, physostigmine, serin, I can't read the last one on the end, but at least to increase acetylcholine availability. Another one, if you can inhibit the sodium channels on the postsynaptic membrane, so tubocurine, curare, alpha bungalowtoxin, so increase with the postsynaptic nicotinic or NM receptor. So they'll pull a couple questions from this, but they will talk about Lambert-Eaton syndrome. And then this blue up in the corner, there's another slide here, so I'm not going to talk about that right now. which is actually this, aminoglycoside antibiotic. So this is going to block the presynaptic calcium channels. So what we're talking about is this right here, presynaptic calcium channels. So at high concentrations, it can block the acetylcholine receptor. Okay, I'm drawing a blank here. Brady, help me with this one real quick. I just had a brain fart.
Doesn't that, well, I know that they talked about the 4-aminopyridine as a potassium channel blocker. Like that, I think that was on the exam.
Yeah, it was.
But I don't remember anything past that. I remember the quantum thing, the quantum content versus size being a big thing, like trying to differentiate, like one is the number of vesicles and the other is the number of neurotransmitters in the vesicle.
Yeah.
Somebody may be able to post the difference. I forget which is content or size. One of them is the number of neurotransmitters.
This would be the content. You're going to decrease the content because the content is the number of the vesicles that are actually able to release their product. So this would decrease the quantum content. Or increase quantum, if you're augmenting acetylcholine, you're increasing quantum content. But yes, you need to know the difference.
Yes, so quantal content has to do with the amount of neurotransmitters in the vesicle, and quantal size has to do with the number of vesicles you actually put out. Yes.
I think you flip those. Quantal size
Probably.
You're good. I'm getting really tongue-tied if you can't already tell. Lambert-Eaton syndrome, this is what we were just talking about, the autoantibodies to the calcium channels right here. So why am I blinking on this? My God, Lindsey. But just know Lambert-Eaton syndrome, please. Please go study that. And then
so I could just point out, so like I think of Lambert-Eaton syndrome very similar to myasthenia gravis, where you have Lambert-Eaton syndrome, you have decreased calcium, presynaptic calcium release, but it has to do, it's almost opposite symptomatically as myasthenia gravis. Like with the Lambert-Eaton, you get increased strength with movement because you're increasing the calcium in the cleft that can bind, whereas myasthenia gravis, with increased movement, you're decreasing the strength because you're binding all those acetylcholine receptors. I think y'all have an actual chart, or maybe just Google online those two, and they'll put a chart up and they'll show you the differences. But yeah, if you put those together in your mind, it'll help you keep them straight.
Yeah,
they both have to do with autoantibodies. Yeah.
Spatial versus temporal summation. This is, I hate to say the word easy, but it's not that complicated. So spatial, you have a lot of different inputs, which is temporal. You have just repeated input from a single neuron. And so the sum of all inputs to a neuron is what is going to determine the action potential. So just the difference between spatial, which means you have a lot, versus temporal means repeated from one. Neurotransmitter removal and degradation. We're going to talk a lot about this in a bit, but it's degraded in the synaptic cleft. Acetylcholinesterase does acetylcholine. Can also be metabolized. So you have MAO, monoamine oxidase. But just understand that there is removal and degradation, and we're going to talk about that more specifically in a bit. And these are just examples, and we're going to get into this in a bit, so I'm not going to go over this slide heavily. I put this slide on here again. I repeated this slide simply because I wanted to talk about vesicular loading. So you have neurotransmitter synthesis. We talked about small versus large, but then you have vesicular loaded. So these are just energy-driven pumps that are going to load vesicles with hydrogen ions, and you have an anti-port system to substitute the transmitter for the hydrogen. I don't think this was a huge thing. If it's a question on the exam, hopefully it's easy for you. So it's just an anti-port system that is substituting a hydrogen for a neurotransmitter. Now, there are 2 or 3 DLAs lectures that kind of go over the same things. I tried to condense it all into one thing, so you're not jumping back and forth between different ones. But now we're going to talk about specific neurotransmitters. Histamine is one of them. It's stored in the TMN, and it's associated with circadian rhythm. You're going to hit this hard in either NB2 or NB3. I don't remember which one it is. And then there's a lot of innervation, but again, all of this stuff comes back heavily in more, I'm pretty sure it's NB3. So this stuff right here, that's big later on, but just understand the big thing is just circadian rhythm. And then the histamine decarboxylase, and then you need PLP. Anytime you see something with a cofactor or something, you need to understand it. So just understand that. You have neuroactive peptides, beta endorphins. I put the slide for beta endorphins down here. That's in a subsequent DLA. But this is highly associated with opioid peptides and pain regulating. So when you see beta endorphin associated with the pain regulating pathways, enkephalins, this is inhibition at the synapses of the medulla and spinal cord, and substance P, I think we talk about in a bit, but there wasn't a whole lot of information on substance P in that DLA. And then nitric oxide, this is one of your gaseous neurotransmitters, which means these are very diffusible, very rapidly degraded. You know from ER that and FTM that NO is associated with cGMP as its second messenger system. But this is just more on the gaseous neurotransmitters. It's not a huge thing, just know nitric oxide, and we have some subsequent slides on this. So nitric oxide, so calcium enters the cell, calcium calmodulin form, nitric oxide synthase, and then arginine is converted to citrulline and nitric oxide. So the biggest thing here is knowing arginine. That's a big thing, is the precursor of everything. Mechanism of action. We already talked about arginine. We already talked about synthase, and then the cGMP. And then we already talked about the gases being diffusible. And if it's diffusible, you can do autocrine and paracrine effects. Autocrine meaning self-activation. And then paracrine is going to be next too. So neurotransmitter pathways and roles. This is just an overview. I'm not going to spend much time on the slide. So this is, again, ionotropic versus metabotropic. Ionotropic, you're going to do the nicotinic receptors. It's going to be ion flow, and it's going to be rapid. Muscarinic is metabolic changes, and it's going to be very slow. So glutamate. This has both ionotropic and metabotropic. The big thing here is ionotropic. I wrote this out for you because it doesn't really write it out in the cell. This is your NMDA receptor right here that I'm circling. It is tonically inhibited by a magnesium ion. Now, AMPA, or the kainate receptor, which is another ionotrope, remember ions, is going to allow for potassium, sodium potassium flex. This is going to increase the end plate oh my God, I forgot that. The EPSP, I forgot what it stands for. And then this is going to displace magnesium, causing the influx of calcium. That's the big thing here. That so NMDA receptor blocked by magnesium, but this can be displaced due to an increased EPSP that is resultant from the influx of sodium potassium. The metabotropic, the big one here, just understand that it's both inhibitory and excitatory. This isn't the most high yield for the glutamate. Just understand that glutamate is both ionotropic and metabotropic. That's the big thing here. So glutamate metabolism, there are 3 ways you can get this. There are a lot of slides that talk about this. I did put all the slides on here for completion's sake, but just know that you can get a deamination. So you have glutaminase. This is a really important enzyme you need to highlight, and you have a byproduct of ammonia. You can get it from alpha ketoglutarate. This is a big one. You get transamination. So please understand that. So we talked about glutaminase, talked about alpha ketoglutarate, but understand the differences. Glutaminase is probably the biggest one, honestly, but understand that there are more for them. And then agonist of NMDA receptor, it can activate the receptor to produce a desired response. You understand agonist, you should understand antagonist, which is going to block that action. So PCP is one of the antagonists. So it's going to prevent that receptor activation. Glutamate, this is the recycling we were talking about, the tripartite signaling. So I just zoomed in on this picture. So this is the presynaptic neuron, this is the postsynaptic neuron, and this is your glial cell right here, most notably an astrocyte usually. So we talked about how astrocytes are going to keep neurotransmitters in the synapse, but it can also uptake and recycle. So that's what it's doing here. You have glutamate, sorry, not glutamine yet. You have glutamate that's coming in here. It's released into these synapses. It can bind to the receptor, but this astrocyte here can uptake this glutamate and it can recycle it. In this case, you are going to have glutamine synthetase. That's an important enzyme. Please highlight it. You can get glutamine. And so glutamine can go back up and it can go in and you can do the metabolism of glutamate again. And then it talks about ammonia toxicity. I like to chunk information. You all know that. And so these are all 3 slides that talk about it. This wasn't big on the exam, just the understanding that hyperammonemia, because of an increase of glutamine, can cause neurotransmitter imbalance because it alters the ratio of glutamate to GABA. That's the big thing. Glutamine GABA ratio is altered. And so glutamine is excitatory, GABA we're going to talk about is inhibitory. So if you start altering the neurotransmitter balances, you are going to cause some not so happy effects. Now GABA, these are interneurons are ubiquitous. That means everywhere. The biggest thing here, it's just the main inhibitory neurotransmitter. That's the biggest thing here. So we're going to talk more about the metabolism, but you have metabotropic here, ionotropic here. So this is erased. It says benzos. Benzos are acting on the extracellular, barbiturates are acting on the intracellular part of the GABA A. So the GABA A is going to be your ionotropic in flexichlorine. Your GABA B receptors are going to be your metabotropic. Your G coupled proteins. That's a big thing there. The formation, this is up in the presynaptic neuron. So you get glutamate decarboxylase, which requires PLP. Those are the big things there. Not too big, not too complicated there, but yeah. But the GABA shunt is something that I want you to take note of. So right here in this glial cell, this is where the GABA shunt happens. So transamination, you get glutamine synthetase. Highlight this, glutamine synthetase in your notes or whatever. This is the GABA shunt right here. This is important for the metabolism of GABA, but that's a big thing. This is just including, we talked about GABA A versus GABA B, one being ionotropic, one being metabotropic. Epilepsy is one of those that's associated with low GABA. So if you can't inhibit, GABA is inhibitory. If you can't inhibit, then you can get epilepsy. Glycine, this is touched on it. This is picked as a representation of really what it just says here, honestly. So glycolysis, you get 3 phosphoglycerate. And so byproduct down the line, you get serine, and they can get glycine. And then it allows, you have an ionotropic receptor, and you can get an influx of chlorine, you get hyperpolarization. One thing that can block is strychnine. Please, I'm pretty sure we had a question on strychnine, but it can block this, so you will not get hyperpolarization. Dopamine. You go through dopamine when you talk about basal ganglia. That's really, really, really big in basal ganglia. So right now, just understand, that dopamine is there. It's all metabotropic. You've gone through its metabolism before, so you get tyrosine, L-dopa, and then dopamine. So in this context, we're not going to go over it too much because you're going to hit it really hard with basal ganglia when you talk about Parkinson's disease. Epi and norepi. Think the quick kiss thing, because you're going to have metabotropic, and so inhibitory versus excitatory, it's just your G proteins. That's all it is. So just understand that. And then something that's really important that will continue on an NB, norepi is stored in the locus ceruleus and the diencephalon. Serotonin, this is mood and arousal stored in the raphe nucleus. Again, this is going to be hit more on kind of in the future. But the big thing with serotonin, the big receptor is going to be this 5-HT3. So it lists a bunch of them, but the biggest one is the 5-HT3. And then, of course, the precursor is going to be tryptophan. Acetylcholine. It's excitatory. You need, it's supposed to say choline, not chole, for synthesis, and you get that from diet. So this is where the choline comes in. So you have glucose, you get acetyl-CoA, then you get amino acids, and then this phosphatidylethynolamine, 3-SAM. So they talk about this a lot, and I'm pretty sure SAM was talked about in it. SAM just needing to be for, I forget what SAM stands for, but you can put it in the chat if you remember that. But you need 3 reactions from SAM that was just associated with acetylcholine, then phosphatidylcholine. So it's acetylcholine, acetyl-CoA, choline, and then phosphatidylcholine. And then all of these combined together, you can get acetylcholine via choline acetyltransferase. And then when it gets in the synapse, you have acetylcholinesterase. Meth dealer, yes. These, we've talked about a couple of these, but anything that can mess with the cholinergic pathway can cause bad things to happen. So botulinum, we talked about previously, inhibits the release of acetylcholine from the presynaptic neuron. So you're not going to get any APs in the postsynaptic. Myasthenia gravis, autoantibodies against the nicotinic receptor. Please know this, autoantibodies against the nicotinic acetylcholine receptor. And then I don't think they touched on this the last two very much, but. And then B12, I put this in here for completion's sake. Because we're talking about the SAM, which is the methyl donor. So understand that this is associated with acetylcholine metabolism to get acetylcholine. And so, of course, we know that SAM, you need vitamin B12. So if you have a decrease in this, you could have pathology here. Remember, from DM, it's coming back to elevated methylmalonate levels. So that's interfering with myelination. And Wernicke-Korsakoff syndrome, this is another one that's coming back to haunt you from DM. So this is the one where you get the confabulations, and it's associated with chronic alcohol abusers. So it's associated with B1. Brain metabolism. This was a sobering lecture. I didn't put very much on here simply because I went through that lecture and I didn't remember a whole lot of that being real high yield, but I did put the diseases on here that you need to focus on. But this is just intro completion's sake. In the normal fed state, glucose is the major brain fuel. You should already know that. Brain preferentially uses glucose. You have the GLUT1s, which are it's non-insulin dependent. That's back from DM. You don't need to know that here. But the oxygen consumption is high and consistent because the brain always needs to be going. And so 20% of total respiration at rest. So like I said, I just picked out some of the things that I thought were really high yield. Like don't just skip over that lecture, but I did pick out some things that you do need to understand. Huntington's disease, they're going to have an entire lecture just dedicated to Huntington's and Parkinson's, but you do need to understand it. So the big thing here that he focused on, of course, was the HTT gene. So an antisense oligonucleotide targeting mRNA of HTT. This is what he focused on in this lecture. Yeah. And then knowing the difference between the healthy brain and the diseased brain, you see some ventricular hypertrophy here or ventricular widening here. So that's something that's associated with Huntington's. Again, I'm not going to go through all of this just because this is all of the information from all the lectures. Oh yeah. Autosomal dominant, gain of function, triplet repeat expansion, polyglutamine expansion, all of the genetic things, of course, sobering focused on in this lecture. Spinocerebellar ataxia, autosomal dominant, CAG, repeat expansions. So CGG expansions, increased methylation. So methylation is silent, so an improper development of neuronal synapses. So this is associated with that fragile X. Do you remember that we talked about if you have an intermediate number versus a large number of these expansions, you get different presentations. That's what that's talking about. So if there's only an intermediate number, it's a massive overexpression. So you get adult onset ataxia versus a full mutation, which causes methylation and expression. So then multiple sclerosis. I don't think we've talked about this yet. Autoimmune demyelinating disease in the CNS. Oh, we did touch on this earlier, the CNS versus the PNS. Something that he stresses in this lecture is the oligoclonal immunoglobulin bands, which if you see this in the CSF, it's diagnostic of multiple sclerosis. He hits on this hard in this lecture. I don't remember if it's a lecture or DLA, but he hits on that point hard with respect to multiple sclerosis. Prion diseases, so the misfolded protein, so the normal protein is the PRP. It is soluble, it is anchored to the extracellular side of the membrane. If it gets misfolded, because it gets converted to an infectious form, it becomes insoluble and it'll form plaques. So the spongiform plaques are what cause the actual disease. And then it's the stacks of the beta sheets on top of each other that are the stacks, the plaques. Okay, that is my last slide.
Let us take a 5-minute break and then we will do the tracks. All right, I guess we should go ahead and get started. Save the best for last. These tracks. So here's the thing, it is difficult, but don't make it more difficult than it needs to be. We're gonna try to break it down Well, for better or worse, the best way to learn these is just practice. And you have to practice because you're going left to right and right to left and ipsilateral, contralateral. You got to do questions. So the ones they post, go through them a couple times because this is very highly tested on the exam. So let's talk about the somatosensory system. So first off, 2 sensory pathways you really need to focus on: the ALS, which is going to focus on pain and temperature, and the DCML, which is going to be light touch, vibration, and proprioception. Proprioception meaning your where your body is in space. So example being, they use this clinically. They tell a patient to close their eyes and they lift the big toe up or push it down, and the patient has to say what the doctor did. So you take the eyes out of the equation and you're able to recognize where your body is in space. Okay. So, and again, the cerebellum has a lot to do with that too. But so let's focus on those 2 pathways first. So sensation means it has to go from the body to the brain. So we're going to talk about these tracks as an ascending track, right? They're going from the body to the brain. All right, so a couple definitions. We kind of discussed this, DCML versus the ALS. ALS is more of a primitive system. Remember, we talked about these pain fibers are slower. And then the DCML is more of a complex system. Just make sure you have an understanding of these, the Merkel's disc and Meissner's corpuscle versus the larger receptive fields areas that are deeper, the raphidic corpuscles and the Pacinian corpuscles. So this is just, so for instance, these fast receptors, if you could see here, it'll tell you if you're pressing down on the skin, it'll tell you when you press down and when you lift up, right? So these deeper or these slower pressures is like if you held your finger on the skin. So it'll tell you if the finger's still pressed on the skin, right? So there are different concepts. These fast receptors tell you when you press down and when you lift up. These slow receptors will be able to tell you if you're still pressing down, right? And that's because there's a constant flux saying, yes, it's still pressed down, yes, it's still pressed down, yes, it's still pressed down, right? You see these action potentials. Whereas this, as soon as you press down, it's like, I just pressed down, I just lifted off. Okay, so that's what this is explaining if they give you a question about it. But just so you understand, so just have a general understanding of that. Again, these pain fibers are very slow. Think about it when you stub your toe, right? You have like a second to be like, oh shit, it's gonna hurt, right? So that's why, because these pain fibers take a little while to get to your brain. Okay, and then when we talk about the chemical mediators of pain, when you injure yourself, potassium is effluxed out of the cell, and this means that a depolarization is more likely. So that would imply, because you're bringing the membrane, if you remember from FTM1, you're bringing the membrane potential closer to threshold. So by doing that, you could depolarize easier, so you're much more sensitive to the pain. There's also chemical mediators, substance P, I think P is for pain, and then prostaglandins also are pain mediators as well. Okay, and we're actually getting hardcore into these for term 4, but we're doing NSAIDs and opioids and all of the above. And so yeah, just remember that NSAIDs primarily COX-1 and COX-2, aspirin's an irreversible inhibitor. It's going to decrease your prostaglandins, decrease pain, help with decreasing inflammation, but you just need a basic understanding for this. Opioids bind those pain receptors, mu, delta, kappa, but we're just going to brush over this stuff. And then there's also a positive pain pathway that goes down. So serotonin and norepinephrine actually will help to minimize the pain you feel. Okay, so that's why you feel like a euphoric effect from opioids. That's because the serotonin and norepinephrine are kind of told to release, so they will help inhibit the pain, but they also give that euphoric effect. So a couple more definitions. Allodynia is like a non-noxious stimuli that becomes painful after some sort of injury. Hyperalgesia is a pain that becomes worse after. So the example I like is trigeminal neuralgia. So the trigeminal nerve here, it's a pain syndrome that you get there. it's super painful and it's really hard to treat. So the allodynia, they say that even wind blowing over their face feels like an intense pain. So that's an example of allodynia, right? So it's something that normally this brushing over the face wouldn't feel painful, but after this this stimuli or this pathology, it becomes painful. So referred pain, y'all know about this. It's that visceral pain that kind of crosses with somatic fibers and you feel the pain somewhere else. Lindsey touched on this. So the general sensory system, somatosensory system, remember, is going to be a pseudo-unipolar neuron. When we talk about the special senses, smell, taste, hearing, you're going to have this bipolar neuron. And remember, the motor neuron is multipolar, okay? And then again, this is similar. This is an example of sort of like we talked about earlier. As you can see, if you press down, these slowly adapting fibers are going to tell you you're continuously pressing down, and rapidly adapting will tell you you press down on the skin and then you lift it up on the skin, right? So just be able to associate these. Just because there's more action potentials doesn't mean it's rapidly adapting, okay? Don't get that confused. Slowly adapting has more fibers, rapidly is an on-off switch, right? Okay, and you can see that here. Now, so there's two types of summation. There's temporal summation and spatial summation. Temporal is just one nerve over time, like one receptor over time, how much time, and if you keep tapping it over time, it'll sum up, right? So you get an increased action potential. Now, more importantly is spatial resolution. So this helps with 2-point discrimination. Like, how can you tell 2 points from 1 point, right? So places like on your palm, on your lips, on your face, it's easier to tell 2-point discrimination because you have small receptive fields for that, which means that there's smaller areas to be able to press to recognize. That's why the homunculus has large areas for the face, large areas for the hand, because they're smaller receptive fields, which means they're more high definition, right? So we can look at it here. See, these small receptive fields here allow you to discriminate 2 points versus this larger one. If you pressed here in this larger receptive field, like say on your back, it would feel like just one finger, right? You wouldn't be able to just discriminate between the two. Here with these smaller receptive fields, you'd be able to discriminate. So, and just quickly, just to note, sometimes the receptive fields overlap, but to determine the 2-point discrimination or two separate causes, you can actually have an inhibitory transmission between the middle one, okay? Just in case they ask, but that's not very high yield. Okay, and y'all know the dermatomes. Remember, the ALS, that pain and temperature fiber, is gonna cross at the level of the vertebrae. So it has a lot to do with this dermatonal distribution as well, but we're going to talk about that in greater detail. Remember, T4 is the nipple line, T10 is the umbilicus, L1 is the inguinal canal. And then the clinical correlate with the dermatomes is shingles, right? So you have a chickenpox infection, then the herpes zoster virus stays in the dorsal root ganglia. You get immunocompromised, or it's a lot of times in older people, it gets reactivated, this latent infection, and you end up getting shingles, right? So remember, it's going to cause, it'll be in typically one dermatome or one dorsal root ganglia. So you'll see this strip-like distribution of the rash, which will be strip across the chest, which will correlate to one single dermatome. And here's that 2-point discrimination. So the smaller it is, the smaller the receptive field. So the better you're going to be able to discriminate 2 points. Okay, so you could correlate to this, to the smaller the receptive field, the larger area in the brain, the larger homunculus area that would be correlated, because you could discriminate 2 points versus like on the shoulders, it'd be really hard to discriminate the same 2 points you can discriminate on your hand, right? Just because on the shoulder you have a larger receptive field, and on the fingertip it's very small. Okay, I briefly touched on this, so let's talk about the ALS pathway. We're not going to make this more complicated than it is. We're just going to break it down. So remember, it's a 3-neuron chain, okay? First neuron comes from the skin or wherever the visceral, wherever the sensation's coming from, let's say the body wall, okay? It's going to cross over at the level, right? So if you are on the nipple line, the T4, this is going to cross over at T4, okay? And then the secondary neuron is going to go, after it's crossed over, it's decussated, you're going to go up to the thalamus. Remember, all the sensory pathways that or at least the main ones we're going to talk about, go through the thalamus, okay? So that tertiary neuron is going to go from the thalamus to the primary somatosensory cortex to tell your brain what you're feeling, okay? So we cross at the level, go up to the thalamus on the contralateral side and to the primary sensory cortex. Crosses at the level of the vertebrae. Okay, so again, we see it here. These ALS tracks are going to be where the gray is, but so let's take a look here. So body wall, sensation, again, sensory is going to go through the dorsal aspect, right? The dorsal side to the gray matter here, and then it's going to cross over at the level to this ALS white matter, and then it's going to transverse up. So typically all pain that you're going to feel, like in Brown-Séquard syndrome, which we'll go through, you're going to see a contralateral deficit, all right? Everything below it, because basically the whole pathway up from this pain is going to be contralateral. It crosses over immediately. Again, crosses at the level of the vertebrae. All right, so we got that one down. We can look at it here. You see, again, this is, I put a star. This is one of the three main pathways you need to know for this test. So this PNS, peripheral nervous system axon, comes from the skin or whatnot, wherever the sensation's coming from. It binds to this secondary neuron. The secondary neuron crosses over to that ALS white matter, and the ALS tract comes up to the thalamus and to the somatosensory cortex. All right. Again, one more time. See this primary fiber, it's going to go to the sensory area, the gray matter of the spinal cord. It is going to cross over near the central canal, and then it's going to get to the white matter where this ALS tract is and go straight up to the thalamus to the somatosensory cortex. Again, crosses at the level of the vertebrae. Now, this is interesting. It's a little more complex. I don't want to get too deep into it, but there are inhibitory factors in pain. Like before, we kind of talked about these descending pain fiber pathways like norepinephrine, serotonin can help to inhibit this pain. But if you've ever banged your shin and then rubbed it and it makes it feel better, this is the concept there. So you get an initial pain, and by activating the touch fiber, you can activate it to actually inhibit that pain. So that's the concept of like rubbing, you know, some sort of somatic pain that, and it makes it feel better because this touch fiber will help to inhibit that pain pathway. So if you were curious why that works, that's the thing. Okay, now these tracks get a little more confusing, but this is going to be the face, the cortical bulbar, the trigeminal pain is going to be more on NB2. Okay, so again, it's the same concept, it's just a little different. Trigeminal is going to be sensation to the face. So you're going to get that sensation in the face, that primary fiber. It's going to go down a little bit, which does makes it complicated when you have lesions in this area because it's technically still ipsilateral. But again, this is an NB2 problem. Then it's going to, the secondary neuron is going to cross, go up to the thalamus and to the somatosensory cortex. Again, by all means, the ALS pathway is much more important than understanding this right now. All right, this is made out to be more complicated than it is. Lissauer's tract is basically just a buffer zone, okay? It allows, it's kind of like a detour, right? You know, a side road. So if I have pain coming in from C5, it's gonna cross that C5, but it's also gonna cross 2 levels up and 2 levels down. Just as, it's like a precaution mechanism. It's a safety factor. What it allows is if you have some sort of pain or temperature lesion at one level, you're probably not gonna feel it because you have this, this extra pathway that's helping to send this fiber. But we're going to break it down very simply. This is all you need to know for the test, all right? If you have a lesion between T2 and T10, that's your lesion, right? What we want to look at is the most terminal ends of the lesion. Now, T2 is going to have 2 levels up, it's going to travel, and 2 levels down, right, as that buffer. But all we're worried about is the area within the lesion. So again, T10 is going to have 2 levels down, right? And it's also going to have 2 levels up as a buffer. So what does this mean? That means you're going to feel symptoms between T4 and T8. Okay, so what we're saying is all you have to do is take the lesion and subtract 2 from it within the range, right? And because the T2 is going to have a buffer that goes to T4, T10 is going to have a buffer that goes to T8. Okay, so you're going to feel symptoms in this area. All you do is look at the outer aspects of it, look within the lesion, and count 2 levels within, because T10 is going to be covered, or T8 is going to be covered all the way to T10, and T10 is going to be covered up to T8. So that's that buffer range. Okay, now, so that's what they'll do. They'll say you have a lesion between T2 and T10. Where are you going to feel it at? This is all you need to do. Now, they could ask it in reverse, right? So they could ask you, you feel symptoms between T4 and T8. So then what are we looking at? Well, then you have to know that the lesion is carried above it and below it because of that range. So you just work backwards. Then you know T2 to T10 is the area of the lesion. Okay, so that's all it is. It's just a 2-level buffer zone for every single level. So when we talk about a lesion, we look at the terminal aspects of it, and that allows us to tell us where the symptoms are. The symptoms will always be less than the actual lesion because of this buffer zone. The lesion will always be bigger than the symptoms because of this, right? So you could do it either way. So make sure you could do it both ways, and you'll be able to answer all the questions regarding that. All right, so the DCML pathway, very similar, except where it crosses, where it decussates. So you have that primary touch or that primary sensation there. It's going to go and it's going to come to the dorsal aspect of the spinal cord. It's going to travel up and it's going to cross at the level of the lower medulla, all right? The lower aspect of the brainstem. Makes it easy because, you know, once you get to the brainstem, that's where you're crossing, okay? So at the brainstem, it crosses, then it travels up contralaterally to the thalamus, to the primary somatosensory cortex, all right? So here the DCML is going to cross at the lower medulla. So what we see here is this is where it travels up. The DC is for dorsal column, all right? It's going to travel up the dorsal column. It's going to come in and then travel up the dorsal column on the ipsilateral side. Once it crosses over, it's now called the medial lemniscus, all right? So on questions, you could see them talking dorsal column, you know it hasn't crossed yet. Medial lemniscus, you know it's crossed already. Because remember, we're going from the area of the skin or of the sensation up to the brain, okay? Now, they do differentiate it this way. You have the gracilis fasciculus and the cuneus fasciculus. This all is contained in the dorsal column. I just remember when you're standing up, your legs closer to your midline than your arms. That helps me remember it, but they could differentiate there. So again, the sensation is going to come in to the dorsal side because that's your sensory side. It's going to travel up ipsilaterally. It's going to get to the lower aspect of the medulla, to the brainstem. Then it's going to cross. Then that's going to travel up to the thalamus as the secondary neuron. Then the tertiary neuron is going to go from the thalamus to the area of the brain for sensation, okay? So you just have to work through these, and you can see here kind of how they travel up. Now ask yourself, which one's contralateral and which one's ipsilateral, okay? So remember, this DCML pathway travels up ipsilaterally, same side, until it gets to the medulla and it crosses. This white matter tract, the ACLS, crosses immediately, right? It crosses, comes through the dorsal side because dorsal is sensory. It crosses and then travels up. So this comes into play when we talk about Brown-Séquard syndrome, a hemisection, because we're going to basically cut off all the tracts, all the blood, everything at one single level. So we're going to be talking about this ipsilateral pathway, ascending pathway of the DCML, but it will be the contralateral of the ALS, because remember, the ALS has to cross over to get to this white matter to then travel up. Okay, so again, remember, pain, the sensation is going to come through vibration, proprioception, fine touch is going to come through and proprioception. It's going to come through, it's going to travel up. So we would say this is the arm area, right? This is the leg area. It's going to travel up ipsilaterally, going to get to the lower aspect of the medulla, right? It's going to decussate or cross. Now it's in the medial lemniscus, right? Then it's going to travel up contralaterally, get to the thalamus, then the tertiary neuron is going to go to the somatosensory area. All right, again, lower medulla. All right, so let's trace it out again. Peripheral nerve goes to this area, see the red dot? That's the dorsal column. It's going to travel up until it gets to the lower aspect of the medulla. That's when it decussates. Then it's now called the medial lemniscus. You see the blue dot. It's going to travel all the way up to the thalamus on the contralateral side. The tertiary neuron is going to go to the brain. Okay? Again, crossing at the medulla, the lower aspect of the brainstem. The medulla, remember we talked about those olives there. That helps to point it out. Remember, it's called the dorsal column before it crosses. Once it crosses, it's now the medial lemniscus. Now, we mentioned this earlier. This is your primary somatosensory cortex, Brodmann's areas 1, 2, and 3. This is the lateral aspect. This area is the anterior portion of the parietal lobe, right? The very anterior portion. If we look at the somatosensory area on the inside, you could see that here. This is that posterior paracentral gyrus, right? So that's going to be the area of the leg and the genitals. All right, again, when we talk about it, overlay your homunculus here. Remember the arm's going to be here, the face is going to be down here, but remember the leg and the genitals are going to be on this area and towards the medial side. So again, this is supplied by the anterior cerebral. So if you have an infarction of the anterior cerebral artery, that can affect the legs. The middle cerebral artery can affect the arms and the face and the trunk. So I just want to point this out. If you've ever heard of phantom limb syndrome, understand your arm doesn't really know it's an arm. Your brain knows what your arm is, right? So if you lose an arm or a limb, your brain still for a while assumes the limb's still there. And that's why you feel this phantom limb pain or this phantom limb syndrome. So after a while, the brain has to restructure itself to be able to understand what's initially lost and kind of overlay it with new fibers, right? So that just takes a little time. It has to be reprogrammed. Okay, now again, we're going to talk about trigeminal. Remember, we said this was cranial nerve 5. This is basically a sensation of the face. Again, this is an NB2 problem, but we want to touch on it here. So that primary nerve is going to come in. Here, it travels a little higher up. It's going to travel across and decussate at the pons. Makes it a little more difficult, but we're focusing on the main 3 pathways right now. This is just a little extra. So it's going to cross over to the thalamus and go to the brain. So, but this is just from the face. Okay, and you can see the difference here. So we get the body, we're good there, right? So we have this this touch pathway is going to from the body is going to go to the lower medulla, then cross. It's just the face that gets a little tricky because it crosses a little higher up, or right around that trigeminal nucleus. Then here we're good with the pain pathway, right? The ALS pathway, because it's going to cross right away, okay, at the level of the vertebrae, and then it's going to cross up. Again, the face gets a little tricky because it has to go down before it comes back up, but I'll get into that in more detail later. All right, so let's talk about this. So immediately when you think of this, you should be thinking the dorsal column medial lemniscus is going to travel on the ipsilateral same side once it travels up till it gets to the medulla. The ALS, the white fibers here, it crosses over at the level. So the fibers, the white fibers here, the tracks that are going up correlate to the contralateral pain and temperature, correlate to the contralateral ALS. So that'll help you break it down. So again, these pain fibers come through at the level and then they cross up. So that's contralateral. These touch fibers go to the dorsal column and they travel up ipsilateral till they get to the medulla. So if we wipe out this area, this hemisection, as you can see here, if you wipe this out, you're going to deal with ipsilateral DCML and contralateral pain. Okay. Same thing here, it's just on the opposite side. So pain's crossed already, it's going up contralateral. Touch is going to travel up ipsilateral till it gets to the medulla. So here, if we have a hemisection here, everything below it's affected on this side, right? This is a road and this is a car accident, right? Nothing's getting past it, right? So these touch fibers are ipsilateral, they're not going anywhere. And these pain fibers are contralateral, they can't go anywhere. So this is the clinical implications of that. Now, at the actual level, you knock out everything, right? All of the crossing fibers and everything. So you lose ipsilaterally, you're going to lose everything because those ALS fibers haven't crossed yet, right? They're in the process of crossing. So you have like the fibers here that are affected. Now, ipsilateral, remember, this is the dorsal column medial lemniscus. These fibers, these touch vibration proprioception fibers, travel ipsilaterally until they get to the medulla and then cross. So these fibers are all ipsilateral DCML. Now, the other side is the ALS. Remember, it crosses at the level. So every level here is going to have these ALS fibers that are crossing over. So they're crossing over, but again, here's the car accident. These contralateral fibers can't get past here. Now, why is it 2 levels lower? Well, that's from Lissauer's tract. So 2 levels lower, you can see that the ALS is no longer protected. So all of this red that you can't feel on this is because they travel contralaterally up to the brain, okay? So ipsilateral DCML and contralateral are gonna all cross over and you can't get past this point. So this is very classic. You should be able to work out all of the different situations for this. This is from first aid, same thing. So let's try it again. You lose all of sensation here. You're gonna have motor symptoms too, but we'll get into that. But you lose all of sensation at the level. The DCML travels ipsilateral. You're gonna lose that. These pain and temperature ALS fibers are all gonna be crossing, right? Crossing here. And so that you're gonna lose them there. So it's contralateral ALS. All right. Now, syringomyelia, it's not that complicated when you think about it. So basically, you get a widening of the central canal where the cerebral spinal fluid goes through. So what fibers are we going to affect? Well, we know at this level, whatever level this is where all the pain and temperature fibers are crossing, right? Because we're at some level, typically it's the cervical level, but these pain and temperature fibers are crossing right away. So when you have widening of this central canal, you can get bilateral loss of pain and temperature. So that's classic for syringomyelia because it's bilateral because it's catching that point where they cross at the level, okay? So that's what you get. And a lot of times they talk about it as a cape-like distribution, right? That's classic if you hear that cape-like distribution. Because like I said, in the cervical area, if you get widening of the canal, when these pain fibers cross and they get affected, you get the bilateral loss of pain and temperature along the shoulders. And I have a picture of that. But you could see this widening here. The X means these pain fibers can't get across. So you're losing pain and temperature at that level, okay? Now, if it's lower than it, then these pain fibers are able to cross. They get to this area and they're okay. So the only affected region are going to be the regions at the levels of pain and temperature, okay? And you can see that here. So there was a syrinx that formed in this area. So you basically lost bilateral pain and temperature in this area because that's that central canal is right where the ALS fibers cross, okay, at the level. You can see here, so this patient had some sort of syrinx that formed. Remember, we're protected with Lissauer's tract, right? So the only area that ended up not being protected with the 2-level rule we used is this area. So you're gonna lose bilateral pain and temperature. So that correlates to this, right? What is that, C6? The C6 distribution to the finger, to the thumb. So it's bilateral, right? Because it's that central canal. Cape-like distribution. All right, so you can go through these. I wanted to put them in here for completeness sake, but it kind of goes through individual nerve lesions versus if you lose a dorsal root or some sort of deficit contained to one dermatome. A lot of time, this glove and stockings distribution has to do with things like diabetes, something that causes peripheral neuropathy, right? You lose, a lot of times it's demyelination, so you lose that this saltatory conduction to the terminal ends of your hands and your legs. Then, okay, so this would be an example like we just talked about of syringomyelia, right? This cape-like distribution. So again, these pain and temperature fibers that are crossing can't cross because you have that syrinx in the middle, that widening of the canal, and you get this bilateral cape-like distribution. This is Brown-Séquard syndrome, so we saw that. Contralateral pain and temp, ipsilateral DCML. If you have a complete cord transection, you're losing everything below it, right? Because you can't, there's no tracks to be able to get to the brain. This is a tricky one, this lateral medulla. This is like when we were saying that point where the nerves from the face have to go down a little bit. And then, so it's actually ipsilateral to the face and contralateral to the body. Y'all will get into this later, but this is a very tricky one because it's right at that area where the facial fibers go down and then come back up contralateral. You kind of have to look at it to get it. But like I said, y'all will do that later. And now what happens if you have a problem in the internal capsule, right? So this is the right side of the patient. So the internal capsule, everything is crossed by the time you get to the brain, by the time you get to the internal capsule. Both the body and the face has crossed because internal capsule is the direct route to the somatosensory cortex. So that means you will lose contralateral sensation to the entire body, face included. So here, if you have ipsilateral face and contralateral body, you know you're still around the level of the brainstem because that ipsilateral face hasn't crossed yet, right? Whereas if you have contralateral to the entire body, you're definitely up in the brain because everything is crossed already, okay? And then this is just unilateral loss of somatosensation in one area. So if you had some sort of, so contralateral loss of all sensory modalities there. So you could have motor deficits here. You could see an example if it's up in the brain, right? So you lost innervation, some sort of innervation to the anterior cerebral artery. And so you lost all the pain or all of the sensation to the lower extremity, right? So that's in the area of the anterior cerebral artery. Okay, let's discuss the motor systems. This is way too busy for me. I don't like this, but it is posted in on my additional resources. If you like charts and you want to break this down, it's just super busy. But if that's your thing, then you can go download this stuff and you could take a look at it. It'll help break it down. But the corticospinal tract of the motor system is much more important than the rest. And I'll point that out as we go along. So corticospinal cortex, right? Cortico to the spine. All right. So you're telling the brain. So now the tracks are not going from sensation from the body to the brain. They're going from the brain to the body. The brain has to tell the motor system to move. So that's corticospinal. You have lateral corticospinal and anterior corticospinal. The ones we primarily talk about are these lateral ones, which have to do with limbs. These anterior corticospinal have to do with the trunk. And then remember, bulbar, we said, has to do with the head. So there's also motor movements to the head. These other symptoms are not as important. They're not as highly tested. There's a couple of things I'm going to point out that they like to test on. So here we go. Remember, we said the motor pathway is a 2-neuron chain. You don't go through the thalamus. So the primary lower motor neuron is going to connect directly to the upper motor neuron and travel directly to the primary motor cortex. And you see that here. So this lower motor neuron is going to go on the ipsilateral side. It's going to connect to the secondary motor neuron. This secondary motor neuron is going to travel up ipsilaterally until it gets to the medulla, same area as the DCML, right about. and it's going to cross at the lower medulla. All right, so that makes it easy. So you could kind of put DCML and the corticospinal tract together. They cross around the same area. So the secondary neuron is going to cross at the lower medulla, then it's going to travel up contralaterally till it gets to the primary motor cortex, right? And this is from the face. Like I said, this is more of a NB2 problem. But again, same principle. The secondary motor neuron is going to connect to the lower motor neuron, and then the secondary or upper motor neuron is going to cross over, and then it's going to go up. It crosses a little higher, but that's just because it has to do with the cranial nerves. But this one, by all means, yep.
Is this efferent though? Since it's like it's a motor. So
yes.
It's going from
yeah. Sorry.
Going...
I should have pointed. I'm sorry. Yeah, that's a good point. Right. So we're actually going the other way. Like I said before, it's going from the brain to tell the motor to move. So let me reiterate that. You're going from the brain. You're traveling down. It's going to cross over at the medulla. It's going to travel to the contralateral spinal nerve, and then this lower motor neuron is going to be what tells the muscle to move. Thank you for pointing that out. So right, so the road's traveling the other way, whereas sensation went up from the body to the brain. We're telling the brain has to travel down, cross at the medulla, still the same nerve till it gets to the level that it's going to come out at. The level of the vertebrae, and then that peripheral nerve is going to come through. And remember, that's going to be on the ventral aspect of the spinal cord, right? Because that's our motor side. Okay, and you can see that here. Remember, the ventral horn is going to be where these motor fibers live, and then the lateral fasciculus is going to be funiculus is going to be where those lateral corticospinal tracts travel down. That's going to be for the contralateral muscles. And then the ventral fasciculus, a lot of these fibers travel ipsilaterally, not super important, but that's going to be in regards to the trunk. Okay, so we're gonna reiterate this a few more times. Okay, so like we said, these tracks, these lateral tracks have to do with the limbs primarily, but they're flexor bias tracks, whereas extensor bias tracks, those axial muscles tend to be on the ventral side. And you could see a little correlate here. So they did test us on this. So remember, the gray matter is the muscle, or is the actual cell bodies. So the flexors are going to be on the more medial aspect of the gray matter, and extensors are going to be on the more anterior aspect, right? So just be able to kind of like take a mental picture of this to understand where the flexors and where the extensors are, just in case they ask. All right, so again, let's track down this cortical spinal tract. The brain is going to tell the body it wants to move. It wants to move the arm, let's say. It's going to travel down. It's going to cross over at the lower medulla. It's going to go to the level of the, say, the arm, and it's going to, the lower motor neuron is going to come across and tell the arm to move. Now, what's convenient is that upper motor neuron symptoms and lower motor neuron symptoms are very different, pretty much opposites. So if you have a lesion in the upper motor neurons, you're thinking of spasticity, right? Hyperreflexia, hypertonia, an extensor response, clonus, meaning it's kind of hyperactive, or this spastic paralysis, like you're kind of tonically contracted. Whereas lower motor neuron symptoms, it's more of a flaccid paralysis. So your reflexes are slowed, you have hypotonia, your muscles are weak. The only thing that gets tricky are these fasciculations and fibrillations. Those might seem to go as an upper motor neuron problem, but they're actually lower motor neurons. They're just basically twitches, right? Fasciculations, you could actually see motor neurons, the lower motor neuron kind of twitching, and fibrillations show up on more of like an EMG type or a scanning if you look at those. Okay, so classically ALS, I'm sure y'all heard of it. Lou Gehrig played for the Yankees in like the 30s. He had ALS, and then everybody knows the renowned physicist Stephen Hawking. So what you need to know about ALS is that it's a motor neuron problem. It is all the motor neurons. It's an upper motor neuron disease and a lower motor neuron disease. So you're going to get symptoms of spasticity with the upper motor neuron, you're going to get symptoms of hypotonia with the lower motor neuron. The point is that ALS combines a lot of, or combines all of the motor neurons. And if you're not familiar with Lou Gehrig, you can YouTube him. It's pretty interesting. Like he got pretty advanced ALS before he actually stopped playing with the Yankees. But it's an interesting story. All right, now some people were asking about the vasculature, and it is difficult to try to determine if you have some sort of occlusion or some sort of lesion, how does it affect the spinal cord? So this is a very common one, or commonly tested one, this anterior spinal artery syndrome. If you have a problem here or a lesion here, you could see this area that's wiped out, right? So classically, you could see these sorts of symptoms, right? This paresis and paralysis. The paresis has to do with the somatosensory problems. The paralysis has to do because you're kind of getting into these lower motor neuron areas. I'm sorry, the motor neuron, the lateral corticospinal tracts, right? I've read that the anterior spinal artery kind of covers 2/3 of the spinal cord, but it doesn't look like that here. So you might want to check me on that. But I know sometimes it can actually involve the lateral corticospinal tracts. Okay, so you know, opposed to having to think too much into this, you could think of anterior spinal artery syndrome and try to remember the symptoms for it, and those correlate to more of the anterior aspect of the spinal cord. You're going to get into some other diseases like Wallenberg syndrome and Weber syndrome, I think is the other one. But those are going to be like pica infarcts and other areas where like the dorsal area is affected. So if you kind of have a general understanding of where the nuclei track over, you could kind of understand in the anterior aspect or the ventral side of the spinal cord is going to be affected with this anterior spinal artery injury. But you'll come across questions like that, so just take note of that. So now we'll get into it one more time, STAR, because this is an important track. The brain is going to tell the body to move. It's going to cross over at the lower medulla. It's going to get to the level of the vertebrae. The lower motor neuron is going to come across, right? It crosses this primary motor fiber, or this upper motor neuron is going to go all the way after it crosses the medulla till it gets to the level of the vertebrae. And then the lower motor neuron is what's going to come across, okay? I just wanted to point this out. If they talk about any sort of the primary motor cortex, any important area, the pyramidal cells in layer 5, that's the one they talk about as being the most important. And then you'll get into this later, but there are premotor areas, like the medial premotor area is more of this planned sequence. So like if you know how to comb your hair, right? So your brain has it understood as a planned sequence, kind of like a program, right? So it knows, so this planned sequence, this medial premotor area will kind of tell your body this motor movement, what to do. And then there's this lateral premotor area. This is the medial, this would be the lateral. And that has to do with sensory guided movement. So if you hear a noise and stuff like that, but y'all will get into that more later. The homunculus is pretty much the same for the motor side. Remember, the medial cerebral artery is going to do the vast majority, but towards this medial side, the anterior cerebral artery can affect the lower extremity. Now, very importantly is this internal capsule. So remember, if we have a lesion in the internal capsule, that's the white matter, right? It's taking this information from the gray matter, it's going to travel down, it's going to go, and then in the motor aspect, it's going to cross over. So if you have a lesion in the internal capsule, a lot of times you'll have contralateral paralysis. Now, the sensory fibers travel through this internal capsule too, right? So it's a pathway for all of the gray matter to get through to the spinal column. So if you have a lesion here, you're thinking of contralateral problems. Why is it contralateral? Because by the time you get up here in the brain, everything has crossed over. So you're going to have to work through some of these questions because they're going to give you a lot of symptoms and you're going to have to rule things out. But if everything is contralateral, typically it means you're all the way up in the brain because by this point, everything's crossed over. And this is a different view. This is an axial cut of the internal capsule. Primarily, they talk about this posterior internal capsule. That's where those somatosensory and those motor fibers are gonna cross in the posterior limb. All right. Yeah. So again, so this internal capsule. If we're just talking about some sort of pain problem, what sort of pain? I'd say lower limb, right? Look where we're coming from. And it's wiped out here. So you're going to come all the way down and you'll have some sort of lower limb problem on the contralateral side, right? Because it crosses over at the medulla. So you just have to work through these problems. This is that decussation at the lower aspect of the medulla. So this is where it's going to happen. Everything from the motor side, everything above that is contralateral, right? Once it hits this and it goes down and tell the muscle to move, it's all contralateral. All right, so depending on where in this upper motor neuron is the lesion will kind of tell you whether it's ipsilateral or contralateral. If it's up in the internal capsule, as I said earlier, it's going to be contralateral. But if it's distal to the, remember, because we're going down, right? So if it's distal to where it decussates at the medulla, then you're going to be on the on the ipsilateral side of the problem. Okay, let me say that again. If you're up in, so let's say we have a problem here, right? This is our lesion. So if the motor movement is told to move the muscle and you have a lesion here in the internal capsule, you're going to see the problem on the contralateral side. If the lesion is past the lower aspect of the medulla, then it's going to be on the ipsilateral side of the lesion. So they're going to try to integrate different sensory aspects to it to help differentiate whether it's up here or down here. So you'll have to put a couple of the tracks together, you'll have to overlay them, and you'll have to see where exactly the lesion is. Okay, and that's what I just explained.
One more time. I'm so sorry.
Yeah, sure, no problem. So, okay, so we're talking about the motor movements here, right? So it's going to come from the brain and it's going to go to the muscle. So let's say we have a problem in the muscle over here. If the lesion is in the internal capsule, you know it's crossed already, right? So it's the contralateral internal capsule here or anywhere, or up here in the brain, any lesion that is above the medulla is going to be contralateral. Once it crosses, if there's a lesion in the spinal cord lower than the medulla, it's going to be ipsilateral to the lesion, right? Lesion here, if it's ipsilateral, if we work backwards, it's before the medulla, before it crosses. And then anything in the brainstem up in the brain is going to be contralateral, okay? So the basic point you want to get is, where is the lesion? Is it above the medulla or is it below the medulla? Because that's going to tell you if it's ipsilateral or if it's contralateral. Okay, again, yeah, no worries. So again, upper motor neuron signs, think of spasticity, hypertonia, clonus. Clonus is like you like tap the reflex and it kind of bounces the reflex. So it is like hyperspastic. And then spinal shock, I have a slide for that coming up. Lower motor neurons, again, you're thinking flaccid paralysis. Don't forget, don't get these confused. Even though it's twitching, it's still considered lower motor neuron, okay, these little twitches. So you would expect a +2 on the reflex scale. That would be brisk, that's normal. Anything lower than that will be a lower motor neuron problem, right? Hypotonia, hyporeflexia. Anything exaggerated will be an upper motor neuron problem, right? Spasticity. Just for completeness sake, I wanted to put the bulbar fibers in here too. So usually we talk about cranial nerve 7 in regards to this. This is the facial nerve. So the motor cortex will cross around the brainstem. Y'all will get to this at NB2, I promise. And then you're gonna get the cranial nerve is the lower motor neuron. So the symptoms are the same for the bulbar tracts when it comes to lower and upper motor neurons, spasticity versus flaccid paralysis. It's just a slightly different level where it crosses over. But by all means, focus on the cortical spinal tract right now. All right, so let's look at this. What if we had paraplegia means 2, quadriplegia would be up in the cervical area, so you would lose the ability to move your arms and your legs. But so if we have some sort of spinal cord transection, you're going to, we see here. So first you want to ask yourself, is the lesion above or below the medulla? Well, you see the fibers have crossed, so it's below it. But you see it's a complete transection. So even though it's crossed, you're still going to get bilateral paralysis, right? Because you completely transected it, right? So what kind of symptoms would you expect from this? You would expect sort of upper motor neuron symptoms, so some sort of hyperreflexia. But this is important, this that they'll talk about this spinal shock. So what happens if you get a spinal cord transection? What happens distal to the transection, right? What happens distal to it? Initially, you're going to get flaccid paralysis for about 4 weeks. That's what's considered the spinal shock. And then after that, you're going to get upper motor neuron symptom signs. They're going to give you questions about this. They're going to give you the timeline. Okay, so 2 to 4 weeks is about the time you get this spinal shock. So how does that work here? So let's look back. If you had a lesion here, you're going to get lower motor neuron signs, this spinal shock for the first few weeks, and then you're going to get upper motor neuron signs, that spasticity after that. So that's what they talk about here. So the timeline's important for spinal shock. All right. The other pathways for the motor system are not as important, like knowing when they cross and all that nonsense, if they even do cross, is not super important. If you just have a general understanding of what are the flexors, what are the extensors, you should be fine. So if you understand this table and then the extensor table, you should be good. This is the only thing that gets a little confusing, but is very important. This decorticate posturing versus decerebrate posturing. So let's look at decorticate first. The point is, decorticate is above the red nucleus. The red nucleus is in the midbrain. So if you have some sort of problem above the red nucleus, you get decorticate posturing. That means you're going to get a flexor pose of the arms, okay? So what ends up happening is this flexor pathway, the rubrospinal, because you're above the red nucleus, this rubrospinal tract is predominant. That's why you get flexion. If we look back on these tables, rubrospinal is a flexor tract. Okay, that's why you're going to get flexion. Now, if you have, okay, so this is the posturing. For the football fans out there, if you've seen a wide receiver go across the middle and just get knocked out, right? And if you can YouTube this and go look at crazy hits in the NFL, when they drop to the ground, they're in this flexor pose, right? And it's crazy when you actually look for it, you could see them drop out of the air and they're literally flexed like this. That's because they had they were concussed and they were knocked out, but it was above the red nucleus. So they're falling in the air and their arms stay tonically flexed like this. So that's above the red nucleus. Now, when we talk about decerebrate posturing, that means it's below the red nucleus, which means all the flexor tracts are knocked off. That rubrospinal tract that allowed flexion in the decorticate posturing is knocked out because it's right around the red nucleus. So if you're below the red nucleus, only the extensors are activated. So if you remember, decorticate, your arms are up, it's above the red nucleus. Decerebrate, your arms are down, it's below the red nucleus. So rubrospinal is activated in decorticate. If you're below the red nucleus and you decerebrate, your arms are down, only the extensor pathways are activated, right? And you could see that here. Everything is extended. All right, lastly, let's look at these reflexes real quick. You kind of know these. I just put this here so you could see, remember, 5 and 6, pick up sticks, biceps, 7 and 8, lay them straight. They could ask you questions. I would know the big ones, primarily these, right? 5 and 6 biceps, 7 and 8 have to do with triceps. L4 is typically the patellar reflex. The Achilles reflex is S1. So you definitely want to make sure you know those. Now, this is an important thing. This is called a Babinski. Well, this is called a plantar response. If you stroke the bottom of someone's foot, you would expect a plantar response, meaning you would expect the toes to curl downward. In children under 1 year of age, their their nerves, especially at the terminal aspects, at the feet, they're not completely myelinated. So when you do this, they get a Babinski response, which is this like flailing of the toes, right? This upward movement of the toes. And that is indicative that the myelin is not complete. But in a person older than 1 that has normal the myelination of the nerves, when you stroke the toe or when you stroke the bottom of the foot, you should get this plantar response, right? The toe should curl in. If there's some sort of neuropathy, right? Some sort of neurological problem that has to do with myelination, and you stroke the bottom of the foot, this patient will get the toes will curl upward, right? So that's either indicative of some sort of demyelinating problem, or if the child is under 1 year of age. So you can see, oh, it actually says less than 2. So 1 to 2 years of age. And you'll get this flexor response, right? I'm sorry. Right, so if you're myelinated, they should curl inward. If there's some sort of problem or in a young child, they will curl upward, right, towards the face. All right, myotactic reflex is basically the way the muscle can tell itself to contract, right? So you have this afferent fiber, this 1A fiber. Now it's going to form the inside aspect of the muscle. It's called the intrafusal fiber. So when it feels like it's being pulled, it's able to signal to the efferent limb, to the motor aspect, to contract the muscle, right? So this is what you see here. This, if you, some sort of stretching of the muscle, and this is indicative by this 1A fiber picking up this intrafusal muscle fiber stretching, it will then be able to signal to the efferent or alpha motor fiber to contract the muscle fiber, the extrafusal muscle fiber. So this sensation of stretch on the inside, the intrafusal fiber will tell the extrafusal fiber to contract, right? It helps to coordinate posture and stuff like that. So if you think of the tendon reflex, when you strike the tendon, it can activate the intrafusal muscle fiber, right? Telling it it's being stretched. And that's why you get a reflex. That's why your knee jerks when you do a reflex. So it has to do with the tendon, the intrafusal fiber goes to the 1A fiber, goes through the sensory side, the dorsal side, signals to the motor side, to the alpha motor fiber, and then it'll contract the muscle. All right, and that's basically what's going on here. Same principle, intrafusal fibers contract, 1A fibers picks that up, and then it'll tell the extrafusal fibers to contract. Now, it also has an inhibitory effect on the extensor muscles, right? So if you flex this muscle, you simultaneously have to relax the extensor fiber there. So it does have an inverse property as well. And there's also this Golgi tendon organ. It has to do with proprioception and again, kind of gauges your place in space. But what I really want to talk about is this antagonistic effect. So there's also this 1B fiber. This is going to be your inverse myotactic reflex. This is going to say, this muscle is stretching too much. You're contracting the muscle too much. You need to relax it. And so like if you're bench pressing and you're maxing out and it's just too much on your muscles will just go, right? They'll just fatigue, and it's a safety mechanism so you don't tear the full muscle. So those are those 1B fibers. So this is this inverse myotactic reflex. So the Golgi, so opposed to telling the muscle like the myotactic reflex to contract, it's actually going to, this 1B fiber is going to tell it to relax. It's inverse, right? So you don't want to tear it. So it's an inverse myotactic reflex, meaning it's inhibitory, and that's the 1B fiber. You could see that here. It kind of just, everything you need to know is basically right here. So you get contraction with the 1A, you get relaxation with the Golgi tendon and the 1B. And there's also, like we mentioned, on one side, if you have a flexor response, you have to have an extensor response on the other side. So when you're walking, when some muscles flex, other muscles have to extend. So it's a very complicated process, but just know that both sides of the spinal cord help to work alongside each other so that you can move in coordinated movements. Lastly, these muscle fibers, there are slow twitch fibers, fatigue resistant. So you're thinking of postural muscles being able to stand up. And then the counter opposite of that is these type 2B fibers. So if you're running a sprint, fatigue susceptible, these big muscles that will initially go this anaerobic glycolysis, and they'll burn out pretty quickly. So just know the difference there. 2A is kind of in the middle, but if you know the extremes, you can answer the questions about it. Then lastly, one more image. What scan is this? What are we looking at? It's a you see the bones are darker, so it's an MRI. So is it T1 weighted or T2? Well, we see the fat here, but there's fluid in it, so we can't tell. But if we look at the CSF, if we look at the fluid in the spinal column, you can see it's lit up. So that's a T2 MRI. That is all we have for you guys. Our exam is Monday, y'all's is Wednesday, so we're not going to have a review next weekend. There's just no way. So good luck. Do practice problems. And as always, y'all could reach out to us if y'all have any other concerns. I will post this review a little later on today once it finishes processing.
So for the rest of this stuff, make sure that you, with the eye pathways, that's extremely high yield. So make sure that you understand that. They will ask you many questions over it. So just go over it really well.
Yeah, like the pupillary light reflex and the corneal reflex, those are very important. So you have to know what are the afferent or the sensory sensations, what are the efferent or the motor fibers. So make sure you could differentiate those because it gets a little complicated, especially since you really haven't gotten deep into the cranial nerves yet. But yeah, as always, y'all could reach out to us if y'all need anything. With that being said, I will stop this long video. All done.
4 hours, wow.
I'm dead. I'm sure y'all are dead
My
too.
throat hurts. Like by the end of me talking, my throat was dry and painful.
Yeah. All right, if anybody has any questions, feel free to ask.
I have a quick question.
Yeah, sure.
So can we go back to sphingomyelia? I was just wondering about the one of them, like just one of them is blocked off. I know pain and temperature is there's a deficit there. Is that because it's pushing down on the anterior horn, and that's why you see pain and temperature deficits, and you don't see the other ones?
Yeah, so typically right where it's crossing over, right by the central canal, that's right where those sensory fibers are crossing over. So that's where you feel it. Sometimes that syringomyelia can get so extensive that you actually affect the lateral corticospinal tracts. But just for simplicity, just know that that crossing fiber is where, yeah, that anterior aspect of the of the central canal, that's what's being impinged on. So those crossing fibers are what's affected.
Awesome, thank you.
Yep.
I think somebody asked this in the chat, but what would you guys recommend for extra practice questions?
Honestly, I just stuck to what SGU gave us. So IMCQs, eSoft, and practice questions. I didn't feel like I had time to go outside that.
Yeah, I wish I had a good answer for you. I did post extra questions. I don't think I did them. It's just, you know, people like give you a bunch of stuff and you just put it in a folder and never get to it. But I think they're all posted on my drive if you're looking for extra stuff. But like Lindsey said, I think I just focused on the ones they gave. But maybe go through those 2 or 3 times just to make sure you can differentiate all of the other options, right? Like if they give you some sort of lesion in a specific area, you could take the other option and say, well, if it was a lesion here, what would the symptoms be, right? So that's a good way of going about that. Let me see how many questions. Yeah, I got like old IEA questions. Those will be good. Oh, but be careful with this because some of these old IEA questions are really heavy on the cranial nerves. That's because when these questions were written, they tested cranial nerves first on the first test, not on the second test. So be careful with that. because these are obviously old questions. And then I have some, yeah, just some other ones in there, yeah, that y'all can check out.
Thank you.
Yeah, no worries.
Sure.
Yeah, Keisha, you could do whatever you want. You're the boss. All right, I'm done. I'm going to take a nap. Y'all have fun.